Can you see my screen?
Yes, sir.
So, good evening, friends. Mumbai Hematology Group, Alchem, and the event management team from Mice Ideas bring to you the third and the final day of the New Waves at 25th EHA meeting that concluded as usual. We'll do that. Dr. Uday, Dr. Sandeep Shah, immediate typing to introduce various other five of them guests. For that, inaugurated Brigadier Dr. Satyavanjan Das. The speaker ML is Professor Hospital. Next Sunday includes for my advances in management, and the speaker includes Dr. Naresh, myself, webinars at my 46 to the talk, which is on newer dimensions of high-risk myeloma. To introduce him fully, he is consultant hematologist and director, blood and marrow transplant unit at the prestigious Dinanath Mangeshkar Hospital, Pune. I request him to take over.
Right, am I audible?
Yes.
Right, sir. So I'm going to talk about high-risk myeloma, how we define it in 2020. And this is a summary of three of the talks that were given in the EHA. The first one was by Dr. Nikhil Munshi on the biology of high-risk myeloma. The second by Jill Kaur on the cytogenetic classification. And the third was by Jesus San Miguel on the treatment. And I'm trying to concise it and present it in 15 minutes. So we know that in myeloma, lifespan of the patient can vary from a few months to even more than 20 years. And at diagnosis, it's been noted that the number of mutations per patient is between 50 to 500, and it's much more than what you see in acute leukemias. And if you do a transcriptome analysis by RNA-seq of the MRD cells post-induction therapy, it shows that there are more than 700 dysregulated genes as compared to the baseline. The simplest definition of high-risk myeloma by the IMWG was that any patient who has a mortality within 2 years of diagnosis is considered high risk. That's been now modified to mortality within 3 years due to disease progression. In general, roughly about 10% of patients will fall into this category who have an early death. But of course, this is a retrospective definition, and you need to define patients right from the beginning when you diagnose the patient. So the definition of high-risk myelomas can consist of these parameters: cytogenetics at diagnosis, presence of extramedullary disease, plasma cell leukemia, and the presence of circulating tumor cells not mounting to plasma cell leukemia, something new. So we know that presence of extramedullary disease in myeloma has a bad prognosis, and in general, as you can see, the overall survival is much lower than if you do not have extramedullary myeloma. And on the right, this is the data from the total therapy protocol, which also shows a similar thing. It is noted that patients who have extramedullary disease tend to have a higher frequency of gene expression profiling defined high-risk disease. And also, in general, the high-risk cytogenetics tend to occur with a higher frequency in patients who have extramedullary disease. Now, the presence of circulating tumor cells in multiple myeloma is something that is also being attempted to diagnose patients with high-risk disease. And as you can see, patients who have MGUS versus in smoldering myeloma versus an active myeloma, you tend to have a higher percentage of circulating tumor cells. And if you can see here on the right here, if you have less than 0.1 circulating tumor cell per microliter of peripheral blood, if you have more than 0.1 CTC per microliter, you tend to have a much worse prognosis than those who have a higher percentage of circulating tumor cells. The only thing is this tool is not easily available as of now, and it's under investigation. Coming to the common cytogenetic abnormalities by FISH, we know that these are the high-risk features: 14, 16, 1420, 1Q gain, 1P deletion, 414. The 414 is, of course, a little variable. I'll come to that later. And TP53 mutations. The revised ISS score, which incorporates ISS plus the presence of high LDH, which is a notable bad risk factor, and FISH. The ISS1, the RISS1 is patients who have ISS1 with the normal LDH and have standard risk FISH. The ISS3 are now ISS3 with the abnormal LDH and or high risk FISH, and all the others come in between as RISS2. Now, what are the true high-risk genetic factors? So, deletion 17p, as we know, is high risk. But if you have 17p in just about 1 or 2% patients, would that also be as bad as somebody who has a higher percentage of myeloma cells expressing this mutation? So, this has been it's now been shown after a meta-analysis of the European data of more than 1,000 patients. It's been now confirmed that if you have the size of the clonal fraction of more than 55%, that is 55% plasma cells show the TP53 mutation, 17p deletion, then you're going to call it as a high risk deletion 17p. And there is about 6% of patients who have what we now call as double hit myeloma. What is double hit myeloma? You have a biallelic inactivation of TP53. So you have a mutation or deletion on both the arms of the chromosome, and these are the particularly high risk patients. Also, the other definition of double hit myeloma is a patient who has 1Q amplification, that's more than 3 copies, on a background of ISS3. And as you can see, these patients have a particularly bad prognosis with a 2-year survival of just about 20%. What about translocation 414? Now, 414 is not always bad. Bad 414 would be if you have a concomitant deletion 1p32. Then the prognosis tends to be much worse than 414 alone. And there is a good 414 where we know that trisomies of 3 and 5 are good prognostic markers. So if you have a combination of 414 and trisomy 3 and 5, then your prognosis would be better than having 414 alone. Again, not all trisomies are good. If you have concomitant trisomy 21 with 414, then that again makes it a really bad prognostic marker. What about 1416? This was considered as a high risk by the IMWG, but it's a rare entity seen over 3.5% patients. And in the IFM studies, they did not find a prognostic value of this parameter, of this abnormality. So it's a little controversial, not accepted by everyone as a high risk factor. Then deletion 1p is considered to be truly a bad prognostic marker, and amplification of 1q is also a bad prognostic marker. So the IFM has proposed that the IMWG high-risk criteria need to be urgently updated. You cannot just say that those 3 or 4 cytogenetic abnormalities are bad risk, and you need to have we need to have a better definition of the cytogenetic risk, and that they've done on the basis of a large number of patients whom they've treated homogeneously and had a long follow-up. Based on this, they have found that about 55% of patients would fall into the low risk myelomas at diagnosis, high risk in about 15%, and intermediate risk in about 35%. And they've also noted that if you have a 17p deletion, then about 94% of the times it will be more than 55% clonal load, and they would tend to be in the high risk. Whereas if you have a 440, only about 29% would actually be at high risk, in the high risk category. Apart from just having a definition of the disease in the beginning, the response to treatment is also equally important. So response to treatment by assessing the MRD by NGS or by flow, this is now going to come into the practice of myeloma as much as what we have in ALL and in AML. We are slowly moving towards that. So in the IFM 2009 with the Dana-Farber trial, which was MRD, which was VRD plus ASCT versus VRD plus maintenance. In this trial, they noted that patients who achieved an MRD negative state have better PFS, whatever the risk in the beginning. So if you have a patient who has a standard risk and is MRD negative, will have the best response. And if you have a patient who is high risk and has positive MRD, would be the worst response. But in between, you would have patients who have an MRD negative state, despite having a high risk cytogenetics in the beginning, they would do much better, right? Then, as well as patients who have standard cytogenetics but who have an MRD positive state at the end of induction. And the Spanish group has, with equal number of patients, has proven the same thing, that the MRD negativity may abrogate the cytogenetic risk. Now, it's not just how well you respond to treatment, but it's also important to note that the time to progression is also equally important, and therefore an early relapse less than 18 months after you've started treatment will indicate that the patient has a much worse as compared to those who have late relapses. So in general, the risk is dynamic, and you may have some standard risk patients who will have early relapse from treatment and not achieving an undetectable MRD, whereas you may have high risk patients who do not have early relapse from treatment and achieve undetectable MRD state. And to complicate matters further, there is something called a spatial heterogeneity, wherein you know that myeloma is a focal disease sometimes, and unlike in leukemia, as it tends to be focal, you may have a situation where you may have the iliac marrow which shows different genetic markers as compared to the sternal marrow, for example. And there is a spatial distribution in these in the the clones. So this is something which shows the same thing, that they found an abnormality in the sternal sample and not in the iliac sample. So finally, how do we define high-risk patients in 2020? So 17p deletion in more than 55% plasma cells, presence of TP53 mutations, some of the T414 abnormalities, combination of several intermediate risk factors would again put them as high risk, 1q amplification plus ISS3, and poor responders and those who have an early relapse. Just the final slide on how one should treat patients with high-risk myeloma. And the goal of these patients should be to eradicate MRD cells. So you must keep on striving to achieve a complete response and MRD negative state in these patients. So MRD cells are basically the Achilles heel, and they are the reservoir of the state, and therefore you need to achieve MRD negativity. And for this, in general, effective treatment may be a matter of dose intensity, may not be a matter of dose intensity, but more of dose density. So in general, a dose dense regimen would probably fare better than an intensive regimen. And one should think of short sequential therapies, including immunotherapy, daratumumab, maybe upfront to avoid resistance. And to change treatment in case of suboptimal response or early biochemical progression. So early rescue intervention is important. With that, I end my talk. Thank you.
Thank you so much, Dr. Samir, for that wonderful, great talk covering this very important subject of how to define and diagnose high-risk myeloma. So, would you say that the burden of the disease as assessed by, say, PET scan is also important, or it's just the biology of the disease?
I am not sure whether the burden per se, unless you see presence of extramedullary disease, the burden per se has not been spoken about too much in terms of putting the patient in the high-risk category. It is the biology of the disease that is more important.
Right. And do we have now a clear-cut guideline that how the treatment of this group should be different from that of standard risk?
No, there is no guideline, sir. It is just that you must, with whatever regimen you incorporate, you must make sure that you achieve MRD negative state. And if you haven't achieved it, then you must keep on changing the regimen and ensure that you achieve MRD negativity. That's what they say.
Right. And this assessment of MRD negativity will be by?
Would be by either by flow or by NGS, whatever is available.
By one of these two tools. And once again, will PET be important there?
Yes, it will. Yes, by PET as well.
All right. Fine. Thank you so much. That was lovely to listen to you.
Thank you.
So we move on to the first quiz of the day, Kalpesh. Yesterday, unfortunately, we missed the wonderful preparation made by our colleague from Puducherry on Hodgkin lymphoma, Dr. Prashant. And the reason for that was that there was a thunderstorm and he lost his network. So what I thought is that we will, first day we couldn't cover CLL, so we did it in the form of MCQ yesterday. So yesterday we couldn't cover Hodgkin, so we'll try to do that with the help of MCQs. So that's the first MCQ. The question to you is to pick up a false statement regarding nodular lymphocytic predominant Hodgkin lymphoma, NLPHL. So there are 6 statements here, 5 of which are correct, 1 of which is wrong. I will read this to you and then you will have 20 seconds answer. It's a rare lymphoma. Most patients present with early stage, non-bulky disease and nodal disease. Late and multiple relapses keep occurring. There is a risk of transformation to non-Hodgkin lymphoma, DLBCL, diffuse large B-cell lymphoma. Treatment involves various modalities like wait and watch, surgical excision, IFRT, involved field radiotherapy, rituximab monotherapy, or chemoimmunotherapy, which may be immunotherapy in the form of rituximab, CVP, cyclophosphamide, vincristine or vinblastine, prednisolone, ABVD, erythromycin, bleomycin, vinblastine, dacarbazine, or CHOP. Lastly, 10-year survival, overall survival of 10 years is 20 to 30%. So time starts now. 20 seconds for you. So Kalpesh in few seconds will show us your voting pattern.
Sir, please discuss the answer. I will load you the result.
Sure. Can you show me the answer slide? So we will see the pattern a little later, but the false statement was the F. That is 10-year overall survival was 20 to 30% was wrong. 10-year survival is 80%. So this is a very, very good Hodgkin lymphoma. But there are some ifs and buts. It's a rare lymphoma is a correct statement. Out of all Hodgkin lymphoma, it accounts for only 3 to 8%. Most of the patients present with early disease, non-bulky and nodal disease. Yes, 7 out of 10 present like this. Late and multiple relapses keep occurring is correct. It's like follicular lymphoma. It's not easy to cure this. Whatever you do, the disease keeps coming back, but the gaps are large. Interestingly, there's a risk of transformation to non-Hodgkin lymphoma, DLBCL. By the time a patient lives for 20 years, there is almost 1 out of 3 would develop and transformation to DLBCL. And all these treatments are correct. If the patient is asymptomatic, he has got no specific complaint related to the nodes, you can just follow, wait and watch, like again follicular lymphoma. If there was 1 or 2 lymph nodes which you have excised to come to the diagnosis, and after that there is nothing left, you can leave the person alone after surgical excision. If there were a couple of nodes and you have excised one, then you could give involved field radiotherapy over there. Then you have got rituximab as monotherapy. So those patients who are unfit for a combination of chemoimmunotherapy, you could give just rituximab. So old people, which is numerically a small number for this particular type of lymphoma, can be treated with rituximab alone. And then you got this various kinds of chemotherapy, immunotherapy combinations, which may be either like Hodgkin lymphoma using ABVD, or more like follicular lymphoma and DLBCL using CVP or CHOP, because this particular type of Hodgkin lymphoma is CD20 positive. So therefore, these are the various modalities of treatment that you have. Now we'll see the voting pattern. So that's your voting pattern. So almost, what's the percentage here? Sixth one is 36%. Okay. So 1/3 of you got the correct answer when you voted this tall bar over here. The rest of you is spread all over. Okay. Thank you. So I hope by now you are champion of lymphocytic, nodular lymphocytic predominant Hodgkin lymphoma. Samir, are you still there? Dr. Samir Malankari? Samir, have you logged out or you are there? I think he is logged out. We have got some questions for Samir. Now, Dr. Kanchanmala Ghorpade wants to know, how do you define plasma cell leukemia? Is it the same definition of 20% cells as plasma cells in the blood, or an absolute number of plasma cells being 2000? Yes, Dr. Ghorpade, that definition remains. And if it is present in the beginning, it is primary plasma cell leukemia. And if a known case of myeloma evolves into this, then it's a secondary plasma cell leukemia. And the secondary plasma cell leukemia has an extremely dismal prognosis, not to say that the primary is something very good. The question is by Dr. Manu V. What are the specific cutoff to determine circulating tumor cells versus plasma cell leukemia? And what is the test platform for the same? So I think this is almost linked with Dr. Ghorpade's question, that if you have lesser than this, then you call circulating plasma cells. And once again, from the angle of prognosis, they have been divided into 3 groups: less than 5%, 5 to 10%, and 10 to 20%. And of course, you can pick up plasma cells at the level of not morphology, but by flow cytometry, by looking at CD38 and their chronality with kappa and lambda. Another question is by Dr. Kuruba. What is your experience on daratumumab based induction therapy for high-risk myeloma? So you are absolutely right. Either DARA as a part of triplet with either PI or IMID together with steroid, or DARA added to a triplet, like PI plus IMID plus steroid, you add DARA to that. These have been some extraordinary additions to the results, especially from the angle of MRD, and therefore tough lymphomas like high-risk lymphoma, you like to use that. Madhusudan Ganvir has similar question. Daratumumab in first line in high-risk myeloma. So the answer is just exactly what I gave. So with this now we'll move on to the second lecture. That is by Dr. Uday Yanamandra. Dr. Uday is professor in Department of Medicine and is consultant hematologist and bone marrow transplanter at Army Hospital R&R Delhi, and he is going to speak to us on latest in managing difficult myeloma, bird's eye view from EHA 2020. Over to Uday.
So can you see my screen?
Yes.
So first of all, I thank Professor M.B. Agarwal sir for giving this opportunity. So I'll be quickly going through what has been spoken in EHA as far as the myeloma is concerned. Now, any virtual program, it would be as difficult to interpret the graph as this graph is. So I just try to help you out, people, by concising it and by classifying it. So there were a total of 6 educational sessions on myeloma at EHA, other 6 sessions. There were some sponsored sessions. So there were a total of 5 sponsored sessions on myeloma at EHA, and these are the ones with respective times and dates. Now, e-posters, there were 1,374 e-posters, out of which from India we had 45, and total on myeloma were 126 out of 1,374, which was around 10%, and from India we had 7. So these are the ones, from India we had 8 actually, and these are the ones which were presented from India as far as myeloma at EHA was concerned. Now, coming to relapse refractory myeloma, total there were 51 out of 126, around 50% of the myeloma e-posters were referring to relapsed refractory myeloma. So I tried to put in whatever are the important ones out of these in the next few slides for the ease of the viewers. So firstly, coming to the myeloma treatment paradigm, we all used to understand that induction, consolidation, maintenance. But if we see the graph further, the disease will relapse at some point or the other. So the first relapse, then the second relapse, and the time gap between every relapse keep halving. By the time over 4th or 5th relapse, when the disease tumor burden is so high that it becomes a refractory disease, and then we lose the patient. There are certain number of patients who might achieve clinical cure wherein more than 10 years these individuals never had relapse, and this constitutes a very small percentage of myeloma patients. But most do relapse at some point of time. Now, if we look at the development of resistance, now this graph by Dr. Shaji Kumar clearly shows that as the number of treatment cycles increase, the treatment types of regimens and the duration of therapy increases, so the resistance keep increasing for a period of time. Now, the current talk, I'll put it into 2 things. At EHA, what were the things which were spoken which we never knew, and what were the things which we already knew, and there are updates on that. So what we never knew were these newer molecules which were spoken about, of which the BCMA directed therapies, Dr. Sharad Damodar will be talking at the flag end of this particular symposia. I will be concentrating primarily on non-BCMA directed therapies. So there were talks on anti-CD38 molecule, newer molecules, venetoclax, Selmods, and melflufen. So firstly, coming to the anti-CD38 molecule. So this was presented by Dr. Amrita Krishnan as e-poster in 931. So this is mezagitamab. This is a newer anti-CD38 molecule which is undergoing phase 1 and phase 2 trials currently. So she has shown phase 1B data, wherein she has shown that in a dose escalating fashion, 600 mg had a good progression-free survival, and particularly in those patients who were DARA naive, this molecule had a better PFS when compared to who were already treated. Now, if you look at the summary of results presented by Dr. Amrita Krishnan, so in phase 2, the dose which was decided for the phase 2, so in the patients who were evaluable in 17, the response was around 24%, and in those patients who were anti-CD38 naive, the response was around 36%. The second group of drugs which was spoken about was BCL2 inhibitors. So venetoclax, we all understand, and in fact, Dr. M.B. Agarwal had done a recent symposium on venetoclax in various hematological disorders, wherein we spoke about phase 1 and phase 2 trials, and Dr. Vikram Matthews had spoken about all the phase 1 and phase 2 trials in that particular thing. But in this EHA, Dr. Shaji Kumar came up with the updated results of Bellini, which is a phase 3 venetoclax trial. So, wherein venetoclax was combined with BOTI plus dexamethasone. So, venetoclax plus VD versus placebo plus VD. If you look at the progression-free survival, the green curve, it shows a beautiful response when compared to placebo arm. And the reduction in the hazard ratio was 0.6 with a significant p-value. But if you look at the overall survival, it was poorer in the venetoclax arm when compared to the placebo, because there were around 12 deaths in the venetoclax arm versus the placebo arm. Mostly they were related to infection. So it shows that in the phase 3 trial, the venetoclax had a higher infection-related mortality. This is the efficacy. So I showed that it was statistically significant, whereas overall survival was inferior, though this was not statistically significant. The p-value was 0.112. The next group of drugs was CELMoDs. This was spoken by Paul Richardson, wherein CELMoDs stand for cereblon E3 ligase modulators, which are the ones which are the, you can say, the elder brother of lenalidomide and pomalidomide. And they basically try to increase the apoptosis by activating the ILOS and the Icaros pathways. And these particular CELMoDs are very effective in those patients who are already resistant to IMiDs, that is lenalidomide and pomalidomide. And they have shown synergy with dexamethasone, bortezomib, and monoclonal antibodies. So in this particular study, they have shown that the overall response rate was 21% in triple resistant group of patients, triple refractory, wherein more than 2 IMiDs or 1 PI and 1 DARA. So DARA resistant, BOTI resistant, and IMiD resistant patients, the overall response rate was 21%. But if you look at increasing dose, that is, if you give the same drug for 21 out of 28 days, then the overall response rate was 54%. So this drug might be an important drug in the future if this shows a similar benefit in the phase 2 and phase 3 trials. This is a swimmer's plot. If you see, except 3 patients, most of them are doing well in this group of patients. And it also showed that if you see the top PET scan, there was a huge extramedullary lesion here. The extramedullary lesion disappeared by putting these patients on CELMoDs. And if you look at 21 out of 28 days regimen, which is the bottom part of the graph, the swimmer's plot, the response was much better when compared to 10 out of 14 days regimen. The second CELMoD which was spoken about was iberdomide. This is another drug, same mechanism of action. It also has shown preclinical synergism with bortezomib and daratumumab by inducing NK cell proliferation and may rescue NK cell depletion by daratumumab. So by giving this particular drug in combination with dara, there might be a greater synergism. In this particular trial, when iberdomide was given along with dexamethasone, there was an overall response rate of around 32%. And if it was given in those patients who are refractory to daratumumab and pomalidomide, the overall response rate was 29%. So again, this might be another drug which might be beneficial in particularly those patients who are already resistant to IMiDs and to bortezomib. Now, the fourth group of drugs would be melflufen. So this is something like repackaging of the old drug. We all have been using melflufen for ages together. Now, melflufen, these are the various abstracts of melflufen, out of which I have taken Horizon trial because that is one of those trials which has actually gone to a very advanced stage. So, melflufen is an oncopeptide, wherein the novel drug is combined with a peptide conjugate. Thus, it is taken up rapidly by the plasma cells because of the high lipophilicity. And thereafter, inside the cell, the melflufen goes and damages the DNA. So rather than having across-the-board effect of melflufen, particularly as seen in transplantation, wherein by giving melflufen, we will lead to mucositis and various other complications, the renal complications and the cardiac complications of melflufen, because here we are trying to target specifically and allow the drug to specifically go to the plasma cells, the side effects, the collateral damage would be very less, and the schedule is IV once every 28 days. Now, this is a Horizon study which was presented by Matthias, and they have shown an overall response rate in an intention to treat trial of 28%, and in double class refractory, 55% of the overall response rate, and in those patients who are refractory to anti-CD that is daratumumab, a 22% overall response rate, and triple class refractory, 20% overall response rate. So this is another drug which might come up in the future, particularly for those patients who are refractory to daratumumab and to bortezomib. So, but before we go to the further part of the talk, I would like to tell all the students who are particularly listening to this particular presentation, whenever we present anything, any highlights of any of the international conferences, don't just get carried away because most of them are phase 1 and phase 2 trials. And actually, we have to wait for the phase 3 trials to look at the final benefit of these particular drugs. So this, you should take it only as recent advances and just understand that these are the molecules which are in the pipeline. Some of them may see the light of the day, some of them may not. But don't go with the impression by looking at these graphs that these are going to be used from tomorrow's date in various institutes across the country. So this just remains to be recent advances. So keep it only to that much. Now, the second part of the talk would be what we already know. And just to reiterate few things wherein they have presented various data of various trials, the updated data. So, firstly, about the data on patients who are not refractory to botulinum. So, Castor, Endure, Panorama, and Eloquent. These are the four major trials about the patients who are resistant to other drugs other than PI. That means they are not resistant to bortezomib. So you can use any boti-related combinations, either with pomalidomide or with daratumumab or with elotuzumab. Of these, all these things, the latest which was presented both in ASCO as well as in EHA was the combination of selinexor with bortezomib and dexamethasone, and it has shown a median DFS benefit which was statistically significant when compared to just using bortezomib and dexa. The second thing is not refractory to lenalidomide. Now, generally, every time we used to present as refractory to len, refractory to boti, but somehow EHA this time, the various presentations were not refractory to boti, not refractory to lenalidomide. It was the other way around. So, the four major trials, Tourmaline, the Eloquent, Aspire, and Pollux, have shown combination of lenalidomide with various other drugs, which could be carfilzomib, daratumumab, elotumumab, or ixazomib. So, if you look at all these trials, the hazard ratio has come down by using a len-based along with one novel agent. So the basic concept remains to be combine lenalidomide in those patients who are not resistant to lenalidomide with one other novel agent which was never tried before. The next was refractory to lenalidomide and bortezomib. In this, there are the various trials which have been done of using pomalidomide for salvaging patients who are refractory, double refractory to both bortezomib as well as to lenalidomide in combination with one novel agent. Of this, the latest one which was presented actually even in the last year EHA and even this year EHA is the phase 3 optimism, and this time they have presented the updated analysis, and it shows that at 3 years the benefit of combining pomalidomide with bortezomib and dexa versus boti-dexa continues. The same was also presented last year. So they just showed that by extending the study for one more year, the benefit remains and there was no drop in the benefit. The other studies which were presented were carfilzomib pomalidomide dexa, daratumumab pomalidomide dexa, and phase 2 trial of darapom-dex, and phase 3 Icaria trial, where isatuximab along with pom-dex. So all of them have shown that combining novel agents to pom-dex backbone has been beneficial rather than just giving pom-dex in those patients who are double refractory to bortezomib and lenalidomide. I'll quickly skip through slides for the want of time. Lastly, coming to refractory to len, boti, and dara. So those patients who are triple refractory. So what are the options in those particular group of patients other than the newer agents or recruiting them to the clinical trials? So use of selinexor, the STORM trial, the phase 2B study, wherein they have combined selinexor with dexamethasone, has shown that there is a significant ORR of around 26% in patients who are triple refractory. So selinexor is one of those agents which is going into phase 3 trials now in triple class refractory multiple myeloma patients. The other trial of selinexor combination with carfilzomib is a STORM trial, again, which also shown has a ORR of around 70% in those patients who are triple refractory. Combination of panabinostat, this is one of those drugs which actually came and then people forgot about it, but a combination of panabinostat with carfilzomib and dexa shows that in triple refractory patients, even this particular thing can have some benefit in this particular group of patients. So this is what we are looking at. Now, the age-old therapy of VTD pace. This is one thing which I found very, very interesting. This was actually first published in American Journal of Hematology, and thereafter this time in the EHA, they have presented the updated analysis. So VDT pace remains to be a good drug, particularly for those patients who are resistant even to daratumumab. So VDT pace, which used to be an age-old regimen, still carries a weightage in particularly in triple refractory patients. Now, the other general concepts which were spoken to, I will not go into great details, but this most of us know. So when should we start treatment for patients is particularly when there is a clinical progression or CRAP. Those with biochemical progression only may not need immediate therapy. So a presence of clinical features is very important in labeling a patient as relapsed. and treatment is indicated in high-risk disease presentation with renal or neurological complications or doubling of M spike when we are only taking a biochemical progression as a marker. So under these three conditions, even a biochemical progression can be treated. The general principles are supposed to be 2 active classes of therapy with dexamethasone is preferred over doublet, and we should always consider performance status, age and the comorbidities when selecting the drugs and doses. How do we select treatment? So prior drug exposure, toxicity, age, frailty and comorbidity, patient preference, which remains very, very crucial, logistics, high risk versus standard risk, and transplant eligibility. The last point is very important because in India, many patients relapse before even they would have been given the benefit of first transplant. So transplant for those patients who have not yet received the benefit of it even once should be considered. The risk stratification would be based on RISS, the genetic makeup. So we should always do a repeat genetic analysis for the patient when they relapse. What should we do for high risk? So multi-drug combinations, as I have shown you. So MRD negativity does have a benefit in better outcomes for these patients. These are the proposed drug dosings for frailty or risk score. I've just put this line for those people who are interested to read it on a later date. So depending upon the frailty index, you can actually dose the drugs, various drugs in various combinations. The impact of toxicity is very important. So if a patient has any of these side effects, so you should try to avoid the drugs which I have pointed out in the subclassification. As I told you, patient preferences and logistics are very, very important. If a patient prefers only oral regimen, then we should give it accordingly. If a patient is not able to visit the hospital frequently, we should cater for that. IV infusions generally require in-hospital admissions or daycare admissions. That should be taken care of. And combination with less immunological toxicity will allow for less frequent testing and clinical visits. So these are important in Indian scenario. So I would end my talk with this particular slide, and just by concluding that therapeutic advances have led to prolonged survival in multiple myeloma, but it still remains to be a chronic disease. Treatment of myeloma requires a long-term strategy. Key is delivering the best package of treatment at a given stage. Optimal combination and sequencing is the key. Risk stratified approach in clinic is very important, and future will be in developing more individualized approaches. Now, one important thing for the students is there is nothing known as one regimen better than the other regimen, and no trying to compare one clinician with another clinician saying that this clinician started this regimen before the other regimen, because it's a marathon. So it really does not matter how you start off, whether you run the first 100 meters faster or the middle 100 meters or the last 100 meters. The aim is we should win the marathon, not about individual sprints which are parts of this marathon. So don't try to compare regimens or compare clinicians based on regimens, what approach and what the type of regimen which the particular clinician has chosen, because every clinician would try to give the best to his patient. Thank you.
Thank you so much, Uday. So we have some questions for you. A question is there a difference between TP53 mutation and deletion?
Yes, there is definitely a difference, because a mutation, if there is a deletion that has got a poorer prognosis when compared to a mutation, these are totally two different things. One is 17q deletion, we call it, and second is TP53 mutation. So we cannot be using the word TP53 deletion. So it is 17q deletion versus TP53. Yeah, they are different in myeloma. They carry different prognosis.
Thank you. The other question is, when a patient is on 3 drugs like a proteasome inhibitor, an IMID and steroid, and he becomes resistant, how do you know he's resistant to which drug?
So if a particular patient has been given the benefit of 2 drugs or 3 drugs in their full prescribed doses, because before calling a resistance of any particular drug, the most important fact is, in India particularly, we try to give suboptimal dosing, trying to suit for the reality, for the performance status, for the economic reasons and other things. If we are sure about all these factors have been taken care of and the patient has been given the ideal doses, then if a patient has relapsed, let's take on bortezomib and lenalidomide and dexamethasone, he would be considered double resistant both to boti and len, because he has already received the ideal dosing of both the drugs.
Thank you, Uday. So in the form of venetoclax, we have the first targeted therapy in myeloma. So in Bellini trial, was it only for patients who had translocation 11-14, or it was not important to have this translocation when you used venetoclax?
So that was a wonderful question, sir. Because Dr. Shaji had presented two e-posters. I have only shown the Bellini trial. So in the Bellini phase 3 trial, they have done it across the board, irrespective of the translocation. And if we look at the e-poster, so he has given for various cytogenetic abnormalities how the PFS and the OS has differed. Whereas a separate e-poster has shown that of all the cytogenetic abnormalities, the one who have translocation 11-14 are the one which have the best prognosis when compared to other cytogenetic abnormalities. So it can be used across board, but the best benefit is those patients who have 11-14.
So Uday, there was some high mortality in the arm containing venetoclax that was restricted to the patients who did not have 11-14 translocation.
No, sir. That was in the updated Bellini. That was across board, wherein the infection-related mortality was higher, but it was not statistically significant. The difference was not statistically significant.
About selinexor, could you just tell them about the mechanism of action?
So it is a transporter inhibitor. So what it basically helps is to help any of these drugs, that is particularly when we give in combination with bortezomib, it helps in preventing the transportation of that particular element, and that helps in benefiting these patients.
Right. There's a question about carfilzomib dose schedule. So what is the most popular schedule now during induction? And after the induction consolidation is over, what is the schedule for maintenance?
So the ideal schedule still, as far as the studies are concerned, is supposed to be giving a twice a weekly dosage as per the recommended dosage. But because of economic reasons and the type of the vial strength that we receive, most of the people have been using it as once a week. Now, the various important trials which have shown it only with twice weekly dosing, not with once weekly dosing. But there are few phase 2 and phase 3 trials which are coming up with the new dosing schedule. So officially or formally, we cannot comment about it still. But as far as maintenance is concerned, yes, every 15 days during maintenance is become a norm, because there are few studies which have come upon by using KRD versus RD, wherein they have shown by using once in every 15 days, the response remains to be the same as far as carfilzomib maintenance, the progression-free survival is concerned.
Thank you. So those were the questions asked by Dr. Gurveer, Dr. Muruddin Khan, and Dr. Roshni Pandey to Dr. Uday. Just before we close this session, I would like to just bring out one very controversial data that was presented in this meeting. That was from endurance trial. This was a trial which was long awaited. Work was going on for many, many years. And Shaji Kumar presented this. And this is carfilzomib, len, dexamethasone versus bortezomib, len, and dexamethasone. Now, everyone thought that carfilzomib arm will be something superior. And in general, if you've got a high risk myeloma, you will like to use, this is upfront, like to use carfilzomib based based protocol upfront. And every year one would wait for the results to come out. Finally, the results came out almost after 10 years in this meeting. And to everybody's surprise, KRD was not superior to VRD. The progression-free survival was identical of VRD and KRD. So there was a sort of eye-opener that anything which looks pretty good does not necessarily stand the test of time when you have got the phase 3 control trial in 2 arms. So you should be very careful in using a drug which is more potent. Just because it is more potent, it is going to be more useful in a patient who's got a high-risk disease is not really right. So with that, we will close this second talk and we will go to the second MCQ, and there is a request from the organizers, and that request is that for voting, you have to click on the live poll button on the top. So unless you click on the live poll, you will not be registered. You do not get your voting register. Okay. So just take care of that. And now we have the second question of the quiz. So this is the second question. As you know that we are discussing Hodgkin lymphoma as far as today is concerned for the MCQ. So this is second MCQ. Pick up the false statement regarding PET scan in classical Hodgkin lymphoma. So we're talking about classical Hodgkin lymphoma, PET scan, 4 statements, 3 correct, 1 wrong. After I read this out, you'll have 20 seconds. So best timings of the PET scan in classical Hodgkin lymphoma are baseline, interim PET scan after 2 cycles, and end of treatment scan done 6 to 8 weeks post chemotherapy. So 3 PET scans at the diagnosis after 2 cycles and 6 to 8 weeks after the chemotherapy is over. Is the first statement. Second statement, PET scans with Deauville score of 0 to 3 are concluded as negative scan. That means that the patient has no active disease. He is in remission. C. Once the PET scan is done, bone marrow biopsy can be skipped. Meaning by, if you've done a PET scan, you need not do the bone marrow biopsy. And last, if PET scan is not available, whole body low dose CT scan is a reasonable replacement. Many parts of India, because of various reasons, availability or cost, you may not have PET scan available. So the statement is, if that is not available, a whole body low dose CT scan is a reasonable replacement for PET scan. So this is for classical Hodgkin lymphoma. Your time starts. So in a couple of moments, we will have your results displayed. So the results are here. 42% of you have voted for the option 4 being the wrong one. That means CT scan low dose is not a replacement for PET, and you are absolutely right. That was a wrong statement. Some of you felt that doing a bone marrow biopsy cannot be skipped if you have done the PET scan, but that is not true. PET scan tells you quite effectively and accurately about bone marrow involvement or otherwise. So in general, today bone marrow biopsy is skipped if you have done a PET scan and if it tells you yes or no about the marrow. And Deauville score of 0 to 3 are negative, 4 and 5 are positive. That means there is a residual active disease, metabolically active disease, if it is 4 and 5. And this first statement was absolutely perfect. In all classical Hodgkin lymphoma, you need 3 PET scans. At diagnosis, interim PET scan at the end of 2 cycle, actually just before the 3rd cycle, at least 10 days after the 2nd cycle, and 6 to 8 weeks after the end of the chemotherapy for the chemotherapy to be over and the results to be seen. This is extremely important, especially the interim PET scan, to know whether your treatment can be de-escalated or it has to be increased. So if you are giving ABVD, whether you have to go to escalated BIACOP. If you are giving ABVD, whether you can drop LEO and go to AVD. So that all is decided by this interim PET scan. This is very, very important for all the students to understand. So that was our second quiz. Is Uday there? Or Uday is logged out?
Yes, sir.
Uday, we have some questions for you. Okay? Okay. So I'll put the questions to you now. Do we need to change the treatment if serum protein electrophoresis shows a spike of 3 grams? I suppose what he says is that you have treated the patient and there is still a spike of 3 grams.
Sir, as far as the previous guidelines were concerned, a cutoff of 3 grams was considered as one of the criteria for treating relapsed refractory myeloma. But But nowadays, a rapid doubling of the serum protein electrophoresis is considered as long as the SPP is more than 1 gram per deciliter. So the current guidelines, the latest by Vincent Rajkumar, speaks of doubling more than 1 gram as a criteria for biochemical progression to be treated in the absence of clinical markers.
There's one more question for you. How will you treat a patient on KRD who has not responded despite 4 cycles? That means 4 cycles of KRD, no response. How will you manage this patient?
4 cycles is, if at all, if it is upfront therapy, 4 cycles is too less. Even if a patient has achieved a VGPR, in that particular given situation, a transplant would be the scenario. But in relapse refractory setting, anything more than 3 cycles, personally, I would like to change it to any other drug. I would like to give a DARA-based therapy. But in this case, you would be the best judge to give the opinion. How would you go about it?
You are absolutely right, because once you have used Len and Carfil, so you do not have a PI left with you. So POM plus DARA and dexamethasone is always there, will be a reasonably good combination, as you mentioned. It's a very interesting question. In a high-risk myeloma, which both of you, maybe both of you can answer, Samir as well as Uday. In a high-risk myeloma, what will be the maintenance protocol? First, Uday.
Sir, on today's date, the data, as you just brought out of the endurance trial, so the data really does not show a benefit. Previously, people used to say based on phase 2 trial that carfilzomib maintenance would be better. But now even a Len maintenance or a Lendex maintenance in these individuals, high-risk myeloma patients, till the time they progress would be a good choice. Unless until the patient has got 14-16 translocation, wherein we would like to choose a cortisone-based therapy. Samir, sir, your opinion?
Yeah. So, in the lecture that I was listening to by Dr. San Miguel, he was commenting about using both a PI and lenalidomide as maintenance. Once you get into a good remission, in these patients, if you've had a good response, say if you've given VRD as the initial induction therapy and then you've gone for an autologous transplant, then you may decide to use either bortezomib plus lenalidomide maintenance, or in a high-risk patient, at least a PI maintenance until relapse.
So, right. I mean, what we are doing in the practice is exactly this, that we are with 2 drugs. And most of the patients have received a PI and an IMID, so we continue with PI and IMID. And of late, as we are having patients who are upfront receiving DARA, then we are continuing monthly DARA with Len. So DARA, Len, or Velcade, Len, or Carfil, Len have become the maintenance therapy. Of course, the distancing becomes the bortezomib given once in 2 weeks, Carfil given once in 2 weeks, DARA given once in a month. All that happens. So the intensity of the treatment is much less, but yes, 2 drugs continue. Recently, there was some data, not in EHA, but published data that you go with MRD. So if the patient is MRD negative, then your maintenance therapy may not be that strong. And all those patients who are MRD positive, your maintenance therapy has to be strong. Talking about the side effects of maintenance therapy, the cost involved of the maintenance therapy. So that can be another angle for future. I must say that in this country, MRD is in its infancy. Be very careful guiding your treatment, even if people are giving you MRD results. This I mentioned yesterday, this I mentioned today, this I mentioned the day before. These last couple of questions had come by Dr. Gopila Gupta, Dr. Abdullah Mosabir, and Dr. Jamesh. So with that, we close the second session, and it's my pleasure to invite now Dr. Sandeep Shah. Dr. Sandeep Shah is consultant hemato-oncologist and bone marrow transplanter at Vedanta Hospital, Ahmedabad. Is also assistant professor and consultant at Gujarat Cancer Research Institute, Ahmedabad. And he's going to talk to us about very interesting topic, high-grade smoldering myeloma from EHA 2020. Over to Sandeep.
Thank you for the introduction, sir, and thank you for this opportunity to talk on high-grade high-risk smoldering myeloma from EHA 20. So I will share my slides. already opened.
Should I ask Kalpesh to open?
No, yes, it's all right.
Okay, try us.
You see it now?
Yes, yes, yes.
Full screen.
Perfect.
Yeah. So there were, I think, two sessions. I mean, one session and two lectures. One from Dr. Saji Kumar in India regarding the how you stratify high risk smoldering myeloma, and second was from Dr. Matthews on the management of high risk smoldering myeloma. And there were only one abstract, which was to REDX trial 10-year data. Otherwise, there was not much on smoldering myeloma in ER. So most of the things which I have taken is from these two lectures, and this abstract is already taken by Dr. Matthews in her lecture also. Few of the slides are from the Dr. Matthews, and most of other slides are made by me. And coming to the old definition of smoldering multiple myeloma, we all know monoclonal protein greater than 3 gram, and or bone marrow plasma cells more than 10%, and absence of graft features. This was the old definition. And we all know that smoldering multiple myeloma is a heterogeneous disease, and some are behaving like MGUS, while some are highly progressive, but still end organ damage is not there, and some are slowly progressive without end organ damage. So today we will be talking about this third group, highly progressive, with still end organ damage is not there. And the current definition, so according to the old definition, MGUS has 1% risk of progression, 10% risk of progression on year, and then MGUS has a 1% risk, while smoldering myeloma carries 10% risk within the first 5 years since diagnosis. Then it is next 5 years it is 3%, and then next 10 years it is 1%. So cumulative probability of progression is from SMM to multiple myeloma is 733% at 15 years. And when SMM progresses to multiple myeloma, there is increase in M protein as well as bone marrow plasma cell, and there is end organ damage. And if we go after 2014, when there is a redefinition of multiple myeloma, where the risk smoldering myeloma was taken into multiple myeloma. So the current definition of smoldering myeloma is asymptomatic disease with an increased growth burden, and the monoclonal protein immunoglobulin or immunoglobulin A is more than 3 gram. Urinary monoclonal protein is more than 500 milligram per 24 hours, or clonal bone marrow plasma cells are 10 to 59%, and no traditional graft features. So if we consider this definition, then conversion to overt myeloma is 3% per year. And NCCN has also the same definition, but absence of myeloma defining events or amyloidosis. And if skeletal survey is negative, then assessment for bone disease with whole body MRI or low dose CT scan or FDG PET CT scan should be done, and then only to be stamped as smoldering multiple myeloma. So we all know that there is as the disease progresses from smoldering myeloma to multiple myeloma, there is increased levels of monoclonal protein, increased myeloplasma cells, and development of end organ damage, which is quantitative progression. And there is also quantitative progression. There is a malignant clone of plasma cells in the marrow. It can be diagnosed by flow cytometry, and this is because of the tumor microenvironment. So, as we already talked that it is a heterogeneous disease, SMM is a heterogeneous disease. So we should know the risk factors that which patients are going to progress faster, and which patient may need treatment earlier. These are the risk factors: tumor burden, which we already discussed, that M protein or bone marrow plasma cells. Then immunoparesis, that means greater than 25% decrease in one or both uninvolved immunoglobulins. immunophenotyping, apparent plasma cells on immunophenotyping, then genetic abnormalities like translocation 414, deletion 17p, and 1 to gain, and radiological assessment. So these are the risk factors which we'll see again in detail. Some risk factors are quantitative, some are qualitative, and some are both. So I will not discuss it again. And there are all these risk factors are validated by different study. So there are multiple studies, and these all studies were discussed by Dr. Saji Kumar in his lecture. Few of them were discussed by Dr. Saji Kumar, and we will discuss some of the risk models which are discussed here later on. And you can see that Bainanchi et al. In 2013 has shows the circulatory plasma cells trial, which show that 5-year time to progression is 25%. If there is abnormality is present, and it is 71% if it is absent. So there are a number of risk stratification models, but the most two popular models are the Mayo risk model, which is based on plasma cell bone marrow infiltration, M component level, and serum FLC ratio. And the second one is Penny's risk model, which is using apparent plasma cells by immunophenotyping and immunoparesis. So in 2007, there was one model by Mayo, which was containing only bone marrow plasma cells and monoclonal protein. In Mayo 2008, there was another risk model which was containing bone marrow plasma cells more than 10%, monoclonal protein more than 3 gram, and free light chain ratio more than 8. And you can see the progression rate. If there is only one factor, then at 2-year progression is 12%. If there are two factors present, at 27%, and if there are all three factors present, then progression at 2 years is 52%. Similarly, this is the Pathema model, and you can see that 5-year progression rate, if none of the factor is present, then it is 4%. If one factor is present, it is 46%, and otherwise it is 72%. And similarly, the median time to progression decreases if there are more factors are positive. And the current risk model which is commonly used is Mayo 2018, which is popularly known as 20-20 or 20-20-20. Bone marrow plasma cells are more than 20%, monoclonal protein is more than 2 gram, and free light chain ratio is more than 20. If we have used 20-20 model, then it is 20 gram per liter. And similarly, if there is a no factor positive, then the 2-year progression rate is 9.7%. If one factor is positive, 26.3% patient will progress at 2 years, and all two factors are present, all three factors are present, then 47.4% patient will progress. So this was another model which was validated by International Myeloma Working Group. And you can see that there are greater than 90% abnormal plasmas also. This is Pathema group. I think that slide is not. I will omit that slide. And this is Pathema group, which we already discussed, that if there are two factors, these factors are present, then progression at 5 years is almost 72%. And these are SWOG criteria, which contains GEP, gene expression profile 70 score more than 0.26, M protein more than 3 gram, and involve free light chain is more than 25. Then if more than two risk factors are present, then progression at 2 years is almost 68%. So these are Mayo and Pathema risk stratification, which again shows that if all three factors are present, then median time to progression is only 1.9 year. If two factors are present, it is 5.1 year. And if one factor is present, then median time to progression is 10 years. Similarly, in Pratyama, if score is 2, then time to progression is 23 months. If score is 1, then it is 73 months. And if score is 0, then time to progression is not reached. Again, these are ultra high risk smoldering myeloma, which were in new classification in 2014. Now we treat them as myeloma because they have myeloma defining events like more than 60% increase in plasma cells, free light chain ratio more than 100, and on MRI or PET CT one or multiple focal lesions. Or so ultra high risk smoldering myeloma, now treated as myeloma, and risk of progression to multiple myeloma is of about 80% at 2 years. So all the patients who have progression to multiple myeloma more than 50% at 2 years, they are considered high risk smoldering myeloma patients. Then there are other risk factors like cytogenetic abnormalities. If patient is having cytogenetic or abnormalities, then again patient has a faster progression compared to no cytogenetic abnormalities. And these are the graphs showing individual cytogenetic abnormalities like translocation 414, deletion 17p, gain of 1q, and hyperdiploidy. So if these abnormalities are present, then the progression is faster. These are again evolving parameters showing that if there is 10% increase in M protein within first 6 months, or 25% increase in M protein within first 12 months, or there is a 0.5 gram hemoglobin reduction in patient, and if these all factors are present, then the patient has a faster progression, faster risk of progression to myeloma. So these were the risk factors which were discussed, and these are the potential future biomarkers for the diagnosis of multiple myeloma. In future, these factors may, if these are factors are positive, then maybe patients are treated as multiple myeloma, like ultra high risk smoldering myeloma. So these are high levels of circulating plasma cells or abnormal plasma cell immunophenotype more than 95%, evaluation of smoldering multiple myeloma, cytogenetic subtypes, high bone marrow plasma cell proliferative rate. If these factors are present, then the chances of progression are more than 50%. So they all are high risk patients. So in future, this will be the scenario that most of the patients, those patients who are high risk, they will be treated like multiple myeloma. Those who are very low risk, they will be treated like MCAS, and a very small proportion of smoldering multiple myeloma patient will remain. So coming to the treatment part of smoldering myeloma, and that lecture was by Dr. Matthews, and she first asked, should we treat to every smoldering myeloma patient, or should we watch and wait for every smoldering myeloma patient? So she represented 4 patients. They all were having smoldering myeloma, but they are different patients. I will not discuss the first 2 patients because they are low risk myeloma and they don't need treatment. So although the diagnosis is same, but they are not identical patients. And the third patient, you can see here the patient falls into the high risk category, and there is 46% progression risk at 2 years. So those patients who fall into high risk category, according to her, those patients should be treated. This is according to this 20-20-20 risk model. This patient has a 46% chance of progression at 2 years. And the last patient also has all 3 factors positive according to 2020, and plus patient had a FISH 1q gain on FISH examination. So this patient had a 59% progression risk at 2 years. So according to her, she will treat these 2 patients and not keep them under observation. So the management of smoldering myeloma should be risk adapted. and she told that she will treat SNM with progression risk at 2 years of 50% according to either 2-20-20 or 2-20-20 plus cytogenetic abnormalities model. So other models, she says that Spanish model has been validated in a clinical trial, so she would treat high risk SMM according to this model. And other models are feasible if they identify patients with a progression risk of 50% at 2 years. So those patients who had a chances of progression of more than 50% at 2 years, those patients should be treated according to her. So why patients are observed and waited without treatment in smoldering multiple myeloma, because there were multiple trials were done with melphalan, thalidomide, tolendonic acid, and other biphosphonates. There was no advantage of time to progression or overall survival, and there were a lot of drug toxicity. So that's why we don't treat smoldering myeloma patients and keep them under observation. But after this risk stratification and more safe and effective new drugs which are available like lenalidomide, so selective treatment of high risk patients may delay the progress of this patient to multiple myeloma, and the toxic side effects of new drugs are also small and the drugs are more effective, particularly lenalidomide. So there were two trials which changed and these two trials were landmark trials, and the first trial was published in New England Journal of Medicine 2013, Q-REDEX trial, where LAND plus DEX was given for high-risk smoldering multiple myeloma patients. There were 9 cycles of induction therapy with LAND-DEX and followed by 2 years of maintenance of lenalidomide compared to observation arm. And all these patients were high risk according to the Mayo and Plathema model, which were published in 2007 and 2008, not the recent 2018 model. And the limitation of this trial was that flow cytometry was not done and routine skeletal survey was done for selecting the smoldering myeloma patients. So at that time, MRI or PET-CT or low-dose CT scan was not done. And if we consider this 2014 definition, then the ultra-risk smoldering myeloma patients were also included in this trial. And you can clearly see that there is a benefit of time to progression for IRD arm compared to the observation arm. And medium time to progression is not reached in LANDEX arm compared to observation arm, where median time to progression is 21 months. And at 40 months also there is a benefit, and at median follow-up of 75 months also there is a benefit of time to progression. Again, there was overall survival benefit was shown at 40 months and as well as in 75 months in the LANDEX arm. And this was the abstract which was presented as an e-abstract by Dr. Matthews himself, and showing the 10-year data. And at 10.8 year also, there was advantage of time to progression, 9 years versus 2.1 years for observation arm. And there was also advantage of overall survival for LANDEX arm. It is still not median overall survival. It is not reached compared to for observation arm. Median overall survival was 7.8 years. So overall survival from progression to active disease for LANDEX versus no treatment, there was no difference. And this suggests that early treatment does not induce more resistant relapse. So those patients who are treated with LANDEX, and if they progress, they don't have the resistant relapse. Even this LANDEX arm has a very good safety profile and no major side effects were there. Even secondary malignancy was in 4 patients compared to in observation arm it was in 2 patients. But the limitation of this trial was assessment of bone disease was limited to skeletal survey and not by MRI or low dose whole body CT. Progression in observation arm was mainly in bone disease and renal failure. So some of these patients may have already bone lesions while taking patient for the trial. And 2014 revised IMWG criteria for diagnosis of multiple myeloma may incorporate some of these patients in active multiple myeloma group. So the benefit which are shown in trial may be actually very small. Only 11% patients were treated with lenalidomide who were relapsed in observation arm, which may explain for difference in overall survival. Another landmark trial is
Please stop here.
yeah, E3A06, which is LAN versus observation in patients with asymptomatic smoldering multiple myeloma. Again, this trial shows benefit of LAN compared to observation arm in time to progression. And the benefit was most in high-risk patients compared to intermediate and low-risk patients. Again, in both the so risk model, Mayo as well as Lechema, the benefit was there in high-risk patients. And this is how to treat patient. There are two models of progression. Either there is static progression or there is spontaneous progression model. In spontaneous progression, there is new appearance of mutations, while in static progression model, there is same mutations are continued. And these patients should be treated as a curative therapy, while these patients are treated with a preventive mode of therapy. And these two trials, GEM Caesar was a multi-center open label phase 2 trial where they have tried to cure these patients. A phase 2 trial combination of carfilzomib, dexamethasone and lenalidomide is given, followed by autologous transplant and again consolidation therapy with carfil, len and dex. And then maintenance therapy is given. And you can see that CR rate increased from 43% to 81% in maintenance arm, while in MRD negativity is also increased from 33% to 62%. And progression-free survival of 92% and overall survival of 96% at 35 months. This was another trial, Ascent trial, again with the curative intent. We won't go in detail. And summary from Dr. Matthews is that SMM is a heterogeneous disease and the management should be risk adapted. It is become easier to identify the high-risk subgroup with progression risk at 2 years of 50%. And Spanish and ECOG trials support the treatment with either Landex or LAN alone. And trials currently ongoing will clarify about other potential combinations, including the curative ones. And genomic models can help us to identify patients who will benefit from preventive versus curative strategies. But NCCN and IMWG don't accept this theory, and still in high-risk smoldering myeloma also the treatment is wait and watch, or patients should be enrolled in clinical trial. And still we don't treat this patient according to NCCN and IMWG guidelines. So even NCCN is telling that high-risk patients should be in clinical trial and observe them at 3 to 6 month intervals. So approach to management is current risk stratification model do not allow us to accurately predict the risk of progression to active disease when
Kalpesh, can we go to the MCQ?
Yes, sir.
So we now have the third MCQ on Hodgkin lymphoma. Once again, you have to pick up the false statement regarding early stage classical Hodgkin lymphoma. So you got 4 options. Kalpesh, can we go to the question? This is the answer. Yeah. So we have got 4 options here. Combined modality therapy, that is chemotherapy plus radiotherapy, is the standard of care for early stage classical Hodgkin lymphoma. B, early stage classical Hodgkin lymphoma should be stratified into favorable and unfavorable risk group. C, Those without bulky disease and no B symptoms are called favorable risk group. And D, favorable risk group is usually treated by 3 cycles of ABVD who have page to majority of you have picked up correctly, and we will discuss this with the help. So combined modality treatment, that is chemo radio, unlike an advanced stage classical Hodgkin lymphoma, is the standard of care for early stage. Now early stage has to be divided into favorable and unfavorable based on bulky disease and B group symptoms. So all these statements were correct. Only thing is that the treatment of favorable risk and a early stage classical Hodgkin lymphoma is not exactly what is shown here. 3 cycles of ABVD and 30 gray. That is a wrong statement. Next slide. Kalpesh, we have one more slide here. Yeah. So there are 3 options for treatment of this favorable risk early classical Hodgkin lymphoma. If you go by the German criteria, simple 2 cycles of ABVD followed by 20 gray radiotherapy. If radiotherapy is not suitable, say for example a girl who has got a disease somewhere in the thorax and you do not want to expose the breast, and even for a male you don't want to expose the coronary to the radiotherapy, then 3 cycles of ABVD as per what is called rapid approach. And then we have EORTC criteria, 2 cycles of ABVD followed by 20 gray radiotherapy, provided interim PET scan done after 2 cycles of ABVD is negative. And in case that PET scan is not negative, it is positive, then the treatment should be escalated to escalated BACOP 2 cycle and radiotherapy should be made 30 gray. So that's the answer to this question. We will go on to the 4th presentation, and I will like to remind the speakers, we strictly have 15 minutes for the presentation. So you will have a bell after 14 minutes and the slides and will be taken off at 15 minutes and you will be muted at 15 minutes. Please take this. Our 4th speaker is Dr. Ajay Sharma, Brigadier Ajay Sharma. He is Professor and Head Department of Clinical Hematology and Center for Bone Marrow Transplantation and Research at Sir Gangaram Institute of Postgraduate Medical Education and Research, Delhi. He is going to talk us about imaging in myeloma from EHA 2020.
Good evening. Am I audible?
Yes.
Good evening. I am going to take up this the topic of imaging in a little classroom fashion because not much has been discussed in this meeting, and as I discussed with Dr. Agarwal, so I'll just give an overview of what has happened in the last couple of years in this field. The imaging is basically, I bring my greetings from my medical college in Shimla and Army Hospital, and now where I'm working in Gangaram Hospital. Now, talking about the imaging, it's mainly concerned with the bone disease, and the bone disease, as we know, is the hallmark of myeloma, and its most frequent and a predominant feature, which is present in about 2/3 of all the patients at the time of diagnosis, and virtually in almost all the patients at the time of the progression of the disease. Despite the remarkable advances, the skeletal involvement is still an important factor in the myeloma because it affects the patient as a whole, has effect on the quality of life, is important for the morbidity and directly related to mortality. If a patient goes to an orthopedician with a fracture, the diagnosis can be delayed if it is not properly investigated, and it also forms the criteria for the diagnosis of the myeloma as one of the criteria. Imaging is actually very important because it identifies the bone lesions which are actually markers of disease-related and organ damage, and they can be actually one of the criteria for starting therapy. Extramedullary disease, which actually is what is picked up by this image, is a very unfavorable prognostic feature in early small myeloma. this imaging helps to differentiate the localized disease from from the, as in the case of solitary plasmacytoma, from a systemic active myeloma disease. And in smoldering myeloma also, it helps to predict the disease of the early progression compared to another patient where there is no evidence of bone disease as such. And so it helps to assess the depth of response in the non-smoldering myeloma, where it have active parameters, and finally it helps to define the MRD negativity or the positivity, as we see subsequently. Conventional radiography has been actually standoff diagnosis for a long time, but it's got limitation. 30% of the times the bone has to be destroyed more than 30% before the lytic lesion becomes apparent, and it is difficult to be identified in spine and pelvis, and sometimes becomes difficult to differentiate from the osteoporosis. It cannot assess the response to therapy, and it might miss the bone disease in about 25 to 40% of the cases. And at the time of detection, considerable bone damage has already taken place, so it's too late to diagnose. So these limitations of conventional radiography led to the search into the use of advanced imaging techniques, because the bone lesions are irreversible, can be detected before the damage has taken place. For that, the novel modalities that have come and are widely used, we'll skip bone scan because it's not being much used, the CT scan, the MRI, and the PET CT. Coming to the CT scan, we actually now will concentrate on the low dose CT scan, because that is what actually is being used now and has got a definite advantage. The whole body low dose CT scan is a convenient modality. It's sensitive enough to detect the small lytic lesions, can pick up the lesion before the fracture develops, and is very useful in spine and pelvis where the conventional cannot help. There's no need for any contrast agents, and this low dose CT scan gives about 50 to 60% less radiation exposure as compared to standard CT scans. And a good scan can identify even plasma cell infiltration on the long bones as the fatty arrow, and it's obviously useful for whenever we need to go for the intervention as CT guide biopsy of the extracellular disease. The CT scan usage has got advantages because it may be sometimes better than MR in the evaluation of areas of risk of fracture, because it defines the bone in a much better fashion. It can identify the bone destruction even in cases where the marrow MRI is normal, and where it's easily possible to be done and convenient for the patient, even if he's got fracture and has got the problem of the posture maintenance for a long time. But there can be fallacies too. It can miss the localized lesions. Next slide, please. And it's good to pick up the lesions, but it cannot assess the improvement or the progression of the disease, and it takes long for the lytic lesions to show any features of resolution. And it, as I mentioned, can assess the progression of myeloma in those areas where there has been prior bone destruction because of either reasons. Coming to the next modality, MRI, it's quite valuable in diagnosing the bone involvement in myeloma, and it actually examines the composition of tissues with regard to water and fat content and can detect bone marrow infiltration by myeloma cells. The myeloma lesions are hypointense in T1 weighted images and hyperintense in T2 weighted images. Focal lesions are a very important thing which this can pick up as the areas of altered signal with a minimum of 5 millimeter size. That is the limit that the focal lesions have been defined. MR can have 5 kind of patterns. It can be normal, it can show the focal involvement, it can show the diffuse involvement, it can be combined focal and diffuse, or it could be variegated salt and pepper lesion appearance. What about the D-weighted diffusion-weighted imaging? Because this is a protocol that is used. This measures the movement of fluid molecules in the bone marrow. The tissue here is a bone marrow without the need of a contrast. If the cellularity is very high, the movement will be limited. If the cellularity is low, the fluid movement will be much higher in the microcirculation. Thus, it can be used to interpret the bone marrow involvement with actually sometimes when we don't need to do a bone marrow aspiration to or the biopsy to study its involvement, though there may be other reasons to the bone marrow study. Doing the fish analysis for and the others. Now, there can be a discordance between the CT scan and the MRI finding, as you can see here in the panel A and B, which are of the MR imaging, and C is the for CT. You can see the T-weighted image which show the high-grade diffuse infiltration of the marrow in the spine, as shown as the diffusely reduced signals in the A panel in the T-weighted images, while they are much increased in the stir images. You can also see in this B panel a localized lesion, while in the C panel, which is the CT scan, there is only non-specific changes in the whole spine, and though it can pick up the localized lesions to some extent. So there is an advantage of the MRI over the CT scan. Where the MRI has been considered as the gold standard of the model of the good efficacy. Because of these definitions of the lesions that can be involved in myeloma, the Derry-Salmon staging system was modified to incorporate these imaging criteria as Derry-Salmon plus staging system, where with the presence of the focal lesions, if they were less than 5, it was stage 1, between 5 to 20 stage 2, and more than 20 stage 3, just to quantify the extent of the bone disease in these patients in comparison to the clinical staging, which actually can guide the see the progression of the disease and the response to the therapy. Coming to the PET-CT, this basically combines the functional imaging with the morphological evaluation of the CT scan. It's an established standard modality in malignancies, especially lymphomas, where it is very extensively used. And now it is being increasingly used in all the stages of myeloma, including prognostication and MRD. Of late, the issues like cost, availability, and expertise are being addressed, and now it is widely available, not very costly also, and there is a good expertise available all over the sectors where myeloma is being treated. And I think this is gradually becoming a part of the management of myeloma in our country also. There are improvements which have taken place in the last couple of years. It has got a high sensitivity. It has got good specificity. We can change the next slide, please. For detection of the both medullary as well as extramedullary disease lesions. The main advantage, next slide, please. I can't move from my slide. Yes, thank you. The main advantage is in the accurate assessment of the metabolically active versus inactive disease, and it can measure the total disease burden, and it's a very simple procedure, single sitting procedure, and the duration is much shorter as compared to the MRI. Identifies hypermetabolic bone lesions up to a resolution of 5 mm. The SU values for myeloma have not been very well validated. Even for lymphoma, actually, now we don't just rely on the SU values. So these can be actually indexed with respect to the background appearance of the spine at L1 and 2 level, or mediastinal blood pool to add the reliability. Because of these limitations, the PET interpretation needs a lot of standardization, validation, and experience, and this limits its widespread application as on now, because it cannot be, even though it is easy to do, but it needs to be interpreted with great care, and good expertise is required. There can be many false positive errors because of the artifacts like metallic implants, physiological accumulation of tissue in joint spaces, inflammation, procedures, fractures, recent chemotherapy, and even use of growth factors. Then we can have the false negative errors because of recent use of steroids, which cause the transient metabolic suppression, hyperglycemia, if the lytic lesions near the brain, plasma cell may not be actually FDG-avid, and there may be low metabolic lesions which might miss the lesions. But the optimal utilization of PET-CT is a dynamic process. It can be used at the diagnosis for the criteria, prognostication, timing of therapy. It can use post-induction, post-transplant, in smoldering myeloma and plasmacytoma, as we see in the next few slides. At the time of diagnosis, even though it is more sensitive, even though MRI is more sensitive, the overall PET is equally effective for the detection of focal lesions, and there's a good correlation between PET and plasma cell infiltration. And though the MRI remains a gold standard for the assessment of the diffuse bone marrow involvement, but which is actually better than even bone marrow morphology, but the PET-CT gives us very good information as far as the overall disease burden is concerned, especially by showing the extramedullary disease. So we can combine the two to have a better assessment. Because of this, the various guidelines have been now incorporated where the PET-CT becomes a part of it and considered for the consideration of the symptomatic myeloma. In smoldering myeloma also, if the whole body skeletal survey is not possible, and with the highly effective novel agents, now the complete remission needs to be much deeply defined. So the role of these imaging techniques comes much more, and also in the MRD. That's why these guidelines have been changed from time to time. It can be used in the prognostication of myeloma to determine the prognosis at diagnosis as well as at the time of relapse. And next slide, please. And it has been prospectively studied, as shown by the study in the next slide that you will see. This study, which has been very recently, looks at the prognostication or at the time of diagnosis. Next slide, please. As you can see in the next slide, which is going to be just yes, you can see the presence or absence of the extramedullary disease at the time of diagnosis. If it is PET negative, the survival rates are much better. Even when in the B panel, as it shows, even if we involve the metabolic parameters, the survival rates are much superior as meant by the PET involvement. So PET actually impacts the overall outcome of the disease, even if we consider other parameters. Next slide, please. Similarly, in the disease with the focal lesions, and if we involve the gene expression profiling, the PET involvement or absence of PET involvement has a definitive determinant effect on the outcome of the disease, considering the event-free survival and overall survival. And it has shown that it is an important marker for the disease assessment and prognostication at the time of diagnosis. After induction, at the time of first auto-BMP also, the same parameters have shown that the PET-CT positivity and negativity impacts the outcome, and it is an important marker at that stage also. Next slide, please. The independent impact of PET-CT, when we either add it to the other parameters like beta-2 microglobulin, LDH, CRP, or gene expression profiling, or independently, the PET-CT definitively has got the impact on the assessment of the outcome of the disease at the time of diagnosis. So these findings, the 3 or more focal lesions with SUV of 4.2 were shown to have adverse outcome in all these situations where patient was transplant eligible or ineligible, or patient subject to the double transplant. In all these imaging parameters, as PET-CT had definitive. Time of the auto transplant also, this next slide please. There is a study which is a little older. It studied at the outcome of these patients after induction when the upfront transplant was taken up. Next slide please. The parameters that were studied were the focal lesions, presence of focal lesions, 3 or more focal lesions, the presence or absence of the extramedullary disease, and the SU values less than 4. Next slide please, 4.2 or less than 4.2. So as you can see in the next slide, the progression-free survival as well as the overall survival in those patients where at the baseline the PET was negative was much superior as compared to those patients where the PET was positive. Next slide please. Even after transplant, the same impact of the PET-CT has been shown. Next slide please. And after transplant also, the survival rates are much better if the PET negativity is maintained. Next slide please. Then looking at the patients who undergo the transplant, next slide please, the PET presence or the PET positivity, or the next slide please, PET negativity as measured by the same 3 parameters, focal lesions, SUV more than 4.2 or less than 4.2, and presence or absence of extramedullary disease. Next slide please. The positivity or the negativity of the PET showed that on the impact on the progression-free survival and overall survival was related to the PET behavior of the patient, and it had a direct effect on the outcome. Next slide please. And similarly, before transplant, if the PET, the SU value was less than 4 as compared to more than 4, the survival rates are much better. Next slide please. And the survival in these patients after the allo transplant was also reflected by the PET negativity. So the negativity before transplant, after transplant, next slide please, has got a definite impact on the disease outcome, and thus the PET is an important reliable tool as a predictor of prognosis in all these stages of disease management. Next slide please. Next slide please. But in detection of the MRD, that's an important consideration because MRD is something which now we look very, very regularly. MRD can be studied on bone marrow with multi-parametric flow cytometry or multiplex PCR, and they can be all combined. But these studies which use the bone marrow aspirate, there can be a fallacy because the bone marrow infiltration by the plasma cells can be very patchy, and the persistence of extramedullary deposit with bone marrow clear of plasma cells can give us the fallacious results. So next slide, please. So if we can combine the PET CT with the bone marrow studies, the assessment can be much better, as was shown in this study, which actually next slide, please. Wherein they had a scoring of the extramedullary disease as well as the presence or absence of the focal lesions, and the SU values 4.2 less than 4.2. Next slide, please. Next slide. And based on that, they had a score of, if all three were present, it was a score of 3. If 2 were present, score of 2, and 1, score of 1. And they showed that if score was 0, score 1, 2, 3, the survival curves were much, much better if the score was on the lower side. So involvement of the PET CT by these parameters, all the survival curves are far superior if the PET shows the much more marked negativity. Next slide, please. So PET negativity after induction, PET negativity, next slide please, at the time of transplant have got a definitive impact on disease outcome. Next slide please. Similarly, coming to the next slide please, coming to smoldering myeloma, the PET positive, next slide please, the PET negativity shows the survival, next slide please, shows the survival. Yes, see, so PET negativity shows the survival for in the favor of the good survival, as the proportion of the surviving patients number is much, much higher as compared to the those patients where the survival curve, where the involvement is much more as shown by the PET. Now, which imaging to choose? In the light of this discussion, probably PET CT is the most cost-effective imaging technique for evaluation and monitoring the response to therapy. PET should be performed for the MRD after initial therapy, and the strength of the PET CT lies in the ability to differentiate stellar tissue from necrosis, which is crucial in the assessment of residual disease. But there are limitations of the PET CT which need to be addressed before its optimal use is adopted. The parameters need to be standardized, and the standardized parameters need to be defined accurately, and they need to be validated. And it can be used for a regular follow-up before therapy, after therapy, because of the high of a relapse in the early phase. So it forms an important investigative tool during the maintenance after the consolidation therapy. So to conclude, the newer techniques of imaging in myeloma have contributed to the improvement in the treatment of all things that we have discussed. They have a definitive role to play and are complementary to one another. It does not mean that one should not follow up these patients by the bone marrow analysis. They all need to be complementary to each other. Since the cost and availability will be an issue, so we need to have algorithm for their optimal use and how they should be optimized. We cannot do all the three modalities in all the patients. They have a role in all aspects of management, from the diagnosis to the MRD evaluation, from BMT to the cure or at the stage of relapse, and they need to be done at the time intervals to have the timely diagnosis of the disease progression. And the newer techniques in the PET CT can efficiently differentiate between the metabolically active and inactive sites, and a number of issues are yet to be resolved in the MRD evaluation as a whole, either by using bone marrow or by assessment of the extramedullary disease by using the functional techniques in addition to the biochemical. On the whole, the PET CT has a role in the follow-up of the patients with active myeloma, smoldering myeloma, as well as solitary plasma. With that, I have concluded, and thank the organizer and Dr. Agarwal for giving me an opportunity to share these moments today with all of you. Thank you.
Thank you very much, Ajay. There are a couple of questions for you. What is the best way to do MRD assessment by imaging?
By imaging. So, as I was discussing here, when we discussed all the three modalities, the PET CT actually scores over all the other three modalities because of the fact that it has a great functional component to the evaluation when we perform it, and it can be quantified. It can be followed up during the post disease, at the time of diagnosis, at the time of transplant, after transplant, and after the consolidation therapy. So for the MRD, we can look for the focal lesions, we can look for the summary disease, and then we can look for the SU values and all to make an algorithm for the serial assessment.
Thank you so much, Ajay. So we will now go to the next MCQ. Kalpesh. So, continuing our MCQs on Hodgkin lymphoma. So, once again, 3 statements are true and 1 is wrong. You have to pick up the wrong statement. This time, Kalpesh has not shown you the answer, so I don't expect a single bar. So, the first one is commonest age group for the classical Hodgkin lymphoma. It's a bimodal, 5 to 10 years. And after 70 years. Second, with over 80% cure rates, late effects of the treatment are taking its toll. And these include second malignancies, cardiac toxicity, infertility, and endocrine abnormalities. C, for advanced stage classical Hodgkin lymphoma, if interim PET scan after 2 cycles of ABVD has got a Deauville score of 4 to 5, the treatment should be intensified to BIACOP 14 or escalated BIACOP and given for 4 cycles. And lastly, replacing procarbazine with dacarbazine in BIACOP is an acceptable option. So 3 statements are correct, 1 is wrong. You pick up the wrong statement, your time starts now. So in a couple of moments, we'll be seeing your results. Kalpesh will show us the histograms. And majority of you are right. Almost 80% have said that the age group mentioned was wrong, and that is perfect. The age group mentioned here was wrong. Can I have the answer slide? Yes. So commonest age group is actually between 15 to 35 years and then after 55 years. It's a very rare disease in the age group 5 to 10. And all other statements were quite correct, that though with the modern modalities of treatment, these side effects have reduced, but you are still concerned about occurrence of second malignancy, cardiac toxicity, infertility, endocrine problem. And your PET scan, if it is positive, Deauville score of 4 to 5 is positive, after 2 cycles of ABVD, you got to move on and escalate the treatment. In fact, if your Deauville score is 5, you probably got to go to the salvage therapy and go with autologous transplant. And in the days of novel agents, of course, these things may totally change. And lastly, yes, replacing procarbazine, which is a nasty drug, with dacarbazine in BIACOP is an acceptable option. So before we move to the next presentation, Ajay, are you there? Brigadier Ajay?
I'm here.
So there is one more question for you. For non-secretory myeloma, would PET-CT be a good method of evaluating the response to treatment?
Yes, I actually mentioned that it has got a special role in these cases where there is a non-secretory myeloma. The biochemical parameters are not useful, but here the presence of extramedullary deposits and other parameters, if they are there, then it certainly helps in evaluation of the disease progression or the responses.
Thank you. There's one more question. Do you make any change in the treatment plan if your PET is positive before you take up the patient for auto transplant?
Well, actually, it's not the question of changing the treatment, but it gives you the prognostication. Suppose if we have a young patient, very young patient, and after giving 3 to 4 cycles of induction, patient has got some biochemical evidence of disease, and MRD is also, the PET-CT shows the presence of the disease. In these cases, we know that the outcome is not going to be good. We can think of actually going in for the tandem auto transplant. We will keep the stem cells for the second transplant. So these kind of considerations can be taken up at the time of transplant. Though based on the PET-CT alone, we don't change any treatment.
Thank you, Ajay. So these questions were by Dr. Raj Bhandari, Dr. Haritha, and Dr. Abdullah Mosabi. Dr. Abdullah is from Bangladesh, Dr. Haritha is from Sri Lanka, and Dr. Raj Bhandari is from Nepal. So you had all international questions. We move on to the next presentation, and that is by Dr. Sharath Damodar. Dr. Sharath Damodar is Clinical Director, MSMC, Senior Consultant Hematologist and Head of Hematology and Bone Marrow Transplant at Majumdar Shah Medical Center, Narayan Health City, Bangalore. And he's going to tell us all about cellular therapies in myeloma.
Yeah, good evening, everybody. I'd like to start by thanking Professor M.B. Agarwal for actually organizing this wonderful 3-day symposium. And I'd like to start by sharing the compliments from my postgraduates and faculty who are absolutely enjoying this session. They've been very thankful attending all the sessions over the last 3 days, and today is the concluding day. And it's an honor to actually give this talk. Now, what I'm going to focus on the next 15 minutes is to discuss the cellular-based therapies in myeloma. Just to continue where Dr. Uday completed his talk, we move on to the immuno-based therapies in myeloma. And in EHA, we had about 3 or 4 talks and about close to 10 or 12 primary abstracts, which are focusing on CAR T-cell based therapies, which is what I will focus on, selecting the best among them. Now, clearly, the targets for immunotherapy or cellular therapy is the BCMA, receptor. Now, what is this? This is a B-cell maturation antigen, which is a receptor protein mainly expressed on the plasma cells and plasma blasts. It transduces signals important for cell survival and proliferation by activating the NF-kappa B pathway and the MAP kinase pathways. And it's part of the TNF receptor family. And clearly, there's enough data to say it's widely expressed, and because of the very high levels expressed in myeloma cells and in patients with relapse affecting myeloma, it certainly is a very good target. And you have close to about 100% expression of this receptor, and clearly, thereby, it is a good target. But learning from our ALL experience in CAR T-cell therapy, you must also remember that when you have one single selective target, you can always have a relapse where the cells can come back without expressing that particular target receptor, just like the CD19 negative ALL relapse, which has been described post CAR T-cell therapy. So this is something to think about, and thereby there's a lot of work going on in that area, even though we've got pretty good responses to the CAR T-cell therapy so far. So what are the surface antigens which have been potential targets in myeloma? Clearly, all of us know the CD38, daratumumab, and isatuximab, which is kind of available. You've got a lot of data on daratumumab. You had a lot of us already using it. People are talking about it even in the previous discussions and using it upfront as a quadruplet therapy. So clearly, this is already there. BCMA is what I'm going to discuss about. There is another target, which is the SLAMF7 target, where elotuzumab is available. That's also a potential CAR target now, and there is some work which is already started in that area as a potential target for CAR T-cell based therapy. Now, when you look at immunotherapy, Primarily, there are three areas where there is work going on. So the first is whether you can actually do something on the T cell receptor itself, which goes and binds to the antigen on the tumor cell. And clearly, you need to bridge that gap of 13 nanometers, which is described there. So they need to come close to each other, bind to the MHC complex there, and then mount an immune response. That's the basis of any of these immune-based therapies. Now, what's the logic used in CAR-T cell therapy? So you've got a chimeric antigen receptor which is expressed by the T cells, which is induced because of the vector which is used there, and then that goes and targets the tumor antigen and then bridges this gap and brings the cell there, and through the T cell mediated cell kill, you're able to kill off the malignant cell. The next step is using bispecific T cell engager antibodies, where you have these antibodies which have got two epitopes, one on either side, one to bring the T, it's like the two arms bringing the cells together, but one on the T cell side, which binds with the CD3 receptor on the T cell, and then the other one targeting the tumor antigen. And then if the cell are close enough, they're brought together, and then this is then used to maintain an manifest immune-mediated response and thereby achieve cell kill. So these are the three strategies which are typically used in any of the immunotherapies in myeloma. And typically we will focus on each of these cell subsets to look at what are the drugs which are available there. Now, these are slides which some of which are from Dr. Sagal Lonial's talk. I think he did the best talk on immunotherapy and CAR-T cell therapies there. And he's divided them neatly in three subsets here. The first one is the antibody drug conjugate, which is belantamab mafodotin. The second is the CAR-T cell subset. We will discuss later on at least 2 or 3 of those which were presented at the EHA. And the last one is the bispecific antibodies. What do we have there? You can see a lot of pharma companies involved here. Clearly, there is a big role. Everybody wants to cash in on this and try and be the first person, entering with this, because clearly there's a huge set of patients in myeloma, especially in the relapsed refractory setting. And clearly, more and more talk. If you listen to the speakers, they're trying to say that rather than wait for fifth line of therapy, why don't we start looking at bringing some of these much earlier on when patients are genetic conditions better off to tolerate these therapies so that you have lesser side effects. So based on this logic, we will discuss this in 3 components. So the first one is the antibody drug conjugate. Like I mentioned, Saga will give a nice little talk on that. This is the data which is also, an abstract from him that was 1897. This is the additional one from the GSK people, which actually make this drug, where they looked at real world outcomes, and this is also put up as an additional poster presentation. And this had the collated data. The basic design of this, the initial one was called the DREAM-1 study. I'll come to what happened there. What was presented here was the DREAM-2 study. This is a phase 2 open-label randomized study in relapsed refractory myeloma patients who are refractory to an immunomodulatory drug, a proteasome inhibitor, and refractory or intolerant to an anti-CD38 monoclonal antibody. In the DREAM-1 study, they did not have people who were refractory to the anti-CD38 antibody. That was the subset that they used. In the DREAM-2, they were even refractory to that, so they were obviously sicker patients. Now, belantamab mafodotin is basically similar to what we've experienced in brentuximab vedotin. So this is a target, this is an IgG, humanized IgG molecule against the BCMA, which is again conjugated with an auristatin F, which is the drug conjugate which is got an anti-microtubule effect against neoplastic cells and produces cell kill. Now, the vedotin which is used in brentuximab in Hodgkin's lymphoma, since you're also talking about that in the quizzes, in the MSQ, is where the CD30 molecule is conjugated with auristatin E. So it's a similar mechanism, but different target and a different drug, slightly tweaked, and that is what is the composition of belantamab mafodotin. And this was a nice drug to kind of use. So this was its single use at 2 doses, which was looked at. The first one was a 3.4 mg per kg, Q3 weekly, and the other was 2.5 mg per kg, Q3 weekly. And they also had a little subset which looked at a lyophilized configuration of that. Clearly, you can look at the subset of the inclusion criteria. Most of them would have had, the inclusion was more than 3 prior lines of therapy. They were refractory to one of these drugs, and clearly they hadn't had any other BCMA targeted therapy in the past. And this was the subset which was looked at. Clearly, this drug has a lot of ocular toxicity, which is already known as one of its complications, and thereby also looking at the side effects which are encountered in the study. and this is something they wanted to look at, whether one of the endpoints was unacceptable toxicity. The primary endpoint obviously was overall response rates, secondary endpoints being duration of response, progression-free survival, overall survival, and a lot of other safety-related issues, including some PK data. So this is what they tried to analyze in this particular open-label randomized study. Now, this is the data which emerged. If you look at it, you can look at the median overall survival of about 14.9 months and the median duration of response of about 11 months in the heavily treated 2.5 mg cohort. If you look at it in the 3.4 mg cohort, it was almost similar. They had a slightly lesser median duration of response. They had some more side effects in that particular subset when they used the higher dose, a slightly higher progression-free survival, and the overall response rates in the range of 30 to 35%. So this is what I want to highlight. When you're using a single agent drug, this is the kind of overall response rates we're looking at. When you look at the graph there, you can see that most of it is actually a PR and a VGPR. You have a smaller number which is CR and stringent CR. So VGPR or better was about 58% of this response when you looked at it from top to bottom. If you looked at it from below upwards, a big chunk is actually PR and a VGPR in this particular study. So lesser of the stringent CRs. Now, if you just looked at it graphically, what about the duration of response? You could see that about 50% of them pulled on till this 12-month overall duration of response, and their overall survival curves almost match each other. To kind of tell you at the end of the day that the 2.5 mg per kg dose was just as good as 3.4. There was no need to really look at a higher dose, which actually had higher toxicities and side effects, and thereby that was the conclusion from this. Now, just one slide on what was the comparison between the DREAM-1 and the DREAM-2 studies. Like I mentioned, the DREAM-1 study did not have patients who had already been exposed to the anti-CD38 antibody. And clearly, you have this subset here, where about 90% of patients were refractory to daratumumab, which clearly tells you that they were worse off and they had also exhausted that option. And in that subset of patients, this drug was being used. And clearly, if you had this kind of response was something worth talking about. That is what they wanted to highlight. They also had a subset of patients who had high-risk cytogenetics, about 40% of them. We've already had discussions in the previous talks on the differences in high risk and standard risk and how their response rates can change. And so they even looked at this subset. Now, just to put into perspective, when we discuss about these immunotherapies, what is the comparator? We should look at the other drugs which are already there. So the combination of single agent drugs like carfilzomib, daratumumab, selinexor, which is also spoken about in the previous talk, and the combination of Bomdex. You look at the response rates, most of them are PR or better response rates in that about 25 to 30% range. VGPR or better response in the single digit or 13% here for DARA, and the median duration of response of about 7 to 8 months, and the overall survival of about 15 to 20 months. If you compare this, the belantamab seems reasonably okay. You're getting 11 months, 14 months overall survival and progression-free survival of 2.8 months, and response rate somewhere in that range or slightly better compared to the other drugs which are currently available. What were the adverse events? Clearly, I did mention the ocular toxicity. So keratopathy is a big problem. There's about 42 to 46% in both the dosages which were used. You've got thrombocytopenia, anemia of about 20% each, and neutropenia in the 11% range. So there are clearly side effects which you need to look at, and this is one of the reasons why this study was focusing on that and tried to focus on the lower cell dose. Now, you just subdivide it into the high risk and standard risk. It seems to work even in the high risk subset. That's what the data shows here. Response rate slightly different, better in the standard risk versus the high risk, but in the lower dose. But their curves are almost running together. So it seems to be a reasonable option even in the subset of high risk and standard risk subset. So that's the first part of the talk, which focused on the antibody drug conjugate. Now coming to the main part, which is the CAR T cell therapy page, I will try and highlight on 2 or 3 presentations which were made and posters which were exhibited there. The first one is S209, which is ID-capped gene Vicucel, called the BB2121, a BCMA targeted CAR T cell therapy in patients with relapsed refractory multiple myeloma from the KAMAR trial. You have a big subgroup of patients sponsored by BMS. This was the data which was presented there. So this is the pivotal study, phase 2 study in patients with relapsed refractory myeloma. Clearly, you can see their inclusion criteria, and this is almost across the board in all the CAR T cell therapy styles. More than 3 prior treatments, and at least more than 2 consecutive cycles of treatment for each regimen, and some of them had to have some bridging before they went on to get the CAR T cell therapy. So that was the general standard. Most of them have had exposure to daratumumab in the past. Clearly, all of them would require one initial lymphodepleting chemotherapy, which is fludarabine plus cyclophosphamide. This is the standard flucy which is given in all the CAR T cell therapies, and then they go on to receive the cell dose. Now, I think there's been some discussion on what exactly CAR T cell therapy was yesterday in the lymphoma talk by Ashish. So I won't go into the mechanisms of how we do CAR T cell therapy, but clearly, whenever you talk about CAR T cell therapies, there is an issue of what is the optimal dose. So most of them would try to use 2 or 3 different doses and try and look at what the response rates before you recommend that particular cell dose for that specific CAR T cell therapy. So this is what is universally practiced. And then based on that, you will then define what are your primary outcomes, your secondary outcomes, and then take a look at what your response rates are. So here they have 3 different cell doses. I will come to that when we look at data. This is presented here. 115 to 10 to the power 6, 300 to 10 to the power 6, and 415 to 10 to the power 6. And most of them were triple refractory, about 30% penta refractory, all of them about 80-90% requiring bridging therapy before they went on to the CAR T cell therapy. If you look at this data in its totality, you have an overall response rate of 73%. So you can see that's really better than whatever I put up so far in the previous studies. In the relapsed refractory myeloma setting, CRs of 31%, median duration of response of about 10 months, median progression-free survival of about 8 to 9 months. When you broke it down into the individual doses, you saw that the cell dose of 415 to 10 to the power 6 did the best. You had about 82% overall response rates, 35% CRs, and a longer duration of about 11 months in the mean duration of response and the progression-free survival. So clearly it is dose dependent, and the higher dose cell dose made some sense here in trying to get a better response. What about the side effects? So whenever you talk about CAR T cell therapy, you have to talk about cytopenias, you have to talk about cytokine release syndrome and the neurotoxicities. Now, if you just look at the CAR T cell therapies in leukemia and in the lymphomas, this is pretty significant if you looked at neurotoxicity and CRS, especially when you look at the grade more than grade 3, which is potentially life-threatening. You have about close to 40% in the leukemias, 20 to 30% in the lymphomas. And surprisingly, in the myelomas, we have very low rates of more than grade 3 toxicity. So this is a big plus for the CAR T cell therapy in myeloma. The rest of the things which are any grade, this is standard description, about 90%, 80%, all of them would get cytopenia and CRS. But the good thing is there is very little grade 3 toxicity. So this is very encouraging to look at the CAR T cell data. I'll go on to the next one, which is the EP926. This is treatment of relapsed refractory myeloma with J&J 4528. This is a CAR-T study. It's nice to see an Indian name there, Deepu Madhuri, who presented this data at the ASH meeting, and this is the subsequent follow-up data which is actually presented here. This is the CAR-T cell therapy from the group from the New York Center, which she's part of, and collaborative multi-center data there. So this was presented initially as a 1A data. This is a 1B data which is on follow-up. Again, like I told you, similar inclusion and exclusion criteria. I won't go into this want of time. All of them have had daratumumab exposure. They've had a pheresis and then lymphodepletion prior to their infusion. And then these are the endpoints we're actually looking at to get response. Now, this is the fantastic data which they presented. If you look at the response rates, they've claimed an overall response rate of 100%. Small number of patients, 29 patients, but this is still decent numbers for a CAR T cell therapy. If you looked at the subset of these patients, 100% of them were triple exposed, 80-90% triple refractory, 76% penta exposed, and about 38% penta refractory to therapy. So they're clearly the relapsed refractory subset of patients. And if you got 100% overall response rates, this is really good data, of which 76% is CR, and then VGPR plus CR is coming to 97%. So this is impressive, and that's the reason I highlighted this part in the previous data which I put up on the belantamab, where we had lesser of this, but clearly you can see the difference here when I put up this curve on the VGPR and the CR rates. Now, if you look at the adverse events, this was consistent with the LEGEND study, which was the original study, which was the Chinese data, which was published with this CAR, which was then used here in the US centers and published as the CAR-T study. Neutropenia, CRS, obviously in the 90 to 100%. Most of them get thrombocytopenia, leukopenia. Neurotoxicity, 14%. Anything more than grade 3, you can see the numbers are smaller, especially neurotoxicity and CRS, small numbers, so not too bad when you look at it from a side effect perspective. This is the third study, which is EP927, orvacaptogene autoleucel or orvacel. This is again BCMA-directed CAR T-cell therapy. This is the phase 1-2 EVOLVE study. One more Indian name, Sham Malankodi. This is from the MSKCC in New York. This data is put up in this table. Again, like I said, it's similar criteria. They again look at the different doses here. The previous studies, they had used 150, 450, and 150, 100, and 450. Here they looked at 300, 450, and 600 in 10 to the power 6 cells. Small numbers, but still, if you look at overall response rates, again impressive. 95%, 94% in these two subset, slightly lesser in the higher cell dose here, probably a little extra toxicity changing that value there. If you looked at the CR data here, stringent CR plus CR, 26%, 50%. And if you looked at all the subset of VGPR and PR, you're getting response rates of 40% and 20 to 30% in this subset. CRS more than grade 3, 0, 5%. So very low, which is the point I'm trying to highlight in all this. So the conclusion was that this is very good efficacy, which is demonstrated here in a subset of heavily treated patients. They did present some updated results of MRD negativity, and impressively, it was almost about 80% MRD negativity, which they assessed. Now I'll come to the last segment of my talk. I'll quickly run through the bispecific antibody, which is a little away from the CAR T. This is the interim results of the first, phase 1 clinical study of the BCL maturation antigen. This is bispecific T-cell engager, one against the BCMA, one against the T-cell. And this was the data. This is the molecule, which is CC93269. If you look at the efficacy data, they used 3 different doses, 3 milligrams, 6 milligram, 10 milligram. The best data was with the 10 milligram, where you had overall response rates of about 90%, with a CR or stringent CR of about 45%. Which tells you that this is a good competitor for the CAR T-cell therapy if you can get similar responses with the BiTE antibody. Quickly to run through the side effects here, CRS of about 23%. Again, not much of the grade 3 toxicities, and thereby something which is pretty useful. And there's a lot of companies which are now involved in the bispecific antibodies. You can see the big list here. I won't run through it for want of time. Just to quickly tell you that there's a lot of activity on this. If you look at the side effects, you see there is cytokine release syndrome and neurotoxicity in both the CAR T and bispecific, but very small numbers, so which is something which is equally comparable. Slowly, CAR T was always thought to be personalized in single patients, but clearly you're getting allogenic CARs which are being made now, which can be used off the shelf, just like the antibody conjugate, and thereby this is another additional utility. I'll just come to a last slide here, which is just 3 slides. At the end of the day, when we're having so much of coronavirus going around in our country, we have to talk about the Chinese and their data. They are one of the pioneers in CAR T-cell therapy. So this is data on a bispecific CAR, and a combination or a dual CAR, combination of anti-CD19 and anti-BCMA. So they put in a dual CAR to a subset of high-risk patients. One set of people got it and the other didn't after an autologous stem cell transplant. So I won't go into the text of this. They defined high risk by standard criteria. They put in the cell doses on day 0 and again day 14 and day 15. And this was the results which they obtained. They got about 86% stringent CRs in this subset of patients who received the CAR after the auto. Just to quickly run through with this last slide, which is showing you the progression-free survival and overall survival, it's almost about 90% to 100% in the subset who got the CAR T after the autologous in comparison to the autologous subset who did not receive the CAR T. And this is in the high-risk patients. So this is a very promising data which has come up. More and more people are looking at the utility of dual CARs, especially when you give it to these patients who are well enough just immediately after the autologous stem cell transplant. This is my last slide. I'll end here and happy to take questions. Thank you.
Thank you so much, Sharad. You made it so nice, beautiful, simple, and of course, a great update. One question for you. What about CAR NK cell therapy?
Yeah, that's the other subset also which is being looked at, sir. I didn't want to go into too much of detail. There is data on that. So the NK cell subset is also being looked at. There is data which was presented there. Clearly, more and more players are getting involved. And now they're trying to tweak, whether we can use combination, you can use individual NK cell as an add-on. And this is again coming up. There was some data which was presented. I deliberately skipped that because the focus was primarily on the primary and the dual CARs. But this is certainly something which is again coming up with a lot of data being generated.
Thank you, Damodar. So, before we go to the last presentation by Dr. Hari, we are going to take up the last 2 MCQs on Hodgkin lymphoma. So, Kalpesh. and you have to pick up a false statement. So brentuximab vedotin is an antibody drug conjugate. B, it is most commonly used for classical Hodgkin lymphoma and CD30 positive anaplastic large cell lymphoma. For which one you feel up? Okay, so all of you got it. The fourth statement was the wrong one, and it was a little tricky. The dose is 1.8 milligram per kg and not per meter square. So fantastic. All of you are very, very attentive. This was just to see how attentive you are. And we go to the last MCQ now. So that's the last one. This is related to the bleomycin lung toxicity, the BLT. Once again, you're going to pick up a false statement. So bleomycin lung toxicity is associated with increasing age. BLT is associated with use of GCSF. BLT is associated with the number of ABVD cycles that you give. BLT has got a mortality of 1 to 3%. Brentuximab vedotin given with adriamycin, vinblastine, dacarbazine in elderly is another way to obviate bleomycin lung toxicity. One of the statement is wrong. Your time starts now. You picked up. So that's interesting. Last two questions, all of you were unanimous in picking up the wrong one. This time, some of you felt that GCSF has nothing to do with it, and that was the wrong answer. And some of them were absolutely bang on target. The mortality of this is not so low, 1 to 3%. So here we are. So as the age increases, the chance of BLT increases. And this is related to age-related decline in the creatinine clearance. 50% of bleo is eliminated by kidney in 4 hours. So if you are 70 or 80-year-old or 60-year-old, your creatinine clearance does come down, and then the bleo toxicity becomes more. About the GCSF, where half of you have gone wrong, it's very important for you to remember when you're using bleo, try to avoid using GCSF. This is a very nice study from Italy showing the incidence of BLT to be 0% when GCSF was not used versus 38% when it was used. So this is probably a bit of exaggeration on either side, but that is the study which is eye-opener. And this is related to pulmonary recruitment of free radical neutrophils by by GCSF, I'm sorry. The BLT is associated with the number of ABVD cycles. You got it correct. So up to 2 cycles, there is no BLT. And then as the number of cycle increases, the problem increases. And that's the reason why after 2 cycles, you do interim scan, PET scan, and drop bleomycin. And especially this is important for elderly people. And lastly, the mortality of this is significant, not that low, 1 to 3%. Mortality of BLT is 18 to 26%. You should watch out for patients on bleo if they get dry cough, breathlessness, do their pulmonary function test, look at diffusion capacity for carbon monoxide, and look at the FVC. And by that, you can pick up the early toxicity and try to salvage them. BV with AVD in elderly is another way to obviate BLT, is the Echelon-1 trial, which is now very popular for the last 2 years. Based on this, even FDA has approved it. So that was my last MCQ, and I hope what we missed yesterday in the Hodgkin disease, part of it we tried to cover it with the form of MCQ. Now it's my pleasure to invite, I would say, the most important talk of the day. And when I say this is because of the subject that Dr. Hari Menon is going to discuss with you. Dr. Hari Menon is is hemato-oncologist, medical oncologist, and bone marrow transplant physician now at Cytocare Cancer Hospital, Bangalore, after working for 2 decades in Tata Memorial Hospital, Mumbai, where he was our colleague and a very active member of Mumbai Hematology Group. I had a great evening with him. Still enjoy him being with me, at least through these webinars. And why I say this is the most important talk of last 3 days is, see, specificities are well learned, but you feel bad when your patient has morbidity and mortality because of things which you have not taken care of. Important is the support of fracture, low hemoglobin. So, Hari's marathon yours.
And wherein as to treat myeloma as a disease, wherein this is also an important part to treat patients. We are on a fora where what was discussed in the EHA meeting with regards to supportive care in myeloma, and I have to say that was it addressed in the EHA 2020? Not really. From that perspective, I had to really search for what might be some relevant data, but I could not find anything which was new. So much of my talk is going to be related generally to supportive care in myeloma, which many of us may already know, and it is just trying to instill the importance of taking care of such patients in our day-to-day practice. So we do understand that multiple myeloma is characterized by several other problems, primarily bone destruction, anemia, renal impairment, and immunological impairment, which are direct consequences of the disease. And this really results in impairment of quality of life for the patient. Though the patients present with many of these symptoms at the time of diagnosis, while we do treat the myeloma and get it under control, some of these symptoms tend to remain, which can impair the quality of life of the patient. And our efforts should be to try and understand these problems and try to alleviate these problems, and also to prevent further problems from occurring by virtue of especially in terms of skeletal related events, which is something that is a constant occurrence even after treating the disease. So the essential components to address from the perspective of supportive care in myeloma are prophylaxis and supportive treatment for osteolytic disease, care of pain, the importance of taking care of anemia, the dealing with renal insufficiency at the time of diagnosis for the patient, also to see how best to improve the renal impairments, and also how best to prevent further deterioration of the renal impairment. Infections, as we know, myeloma is an immunocompromised condition, so infections are very common, and many patients present with infections, and there may be a need for us to actually take measures as prophylaxis against infections. And by virtue of the treatment itself, which we deliver to the patient, thromboembolic episodes and coagulopathy can be a problem, and one of the most debilitating problems, which is peripheral neuropathy. So there are a host of things that we need to address when we deal with myeloma in terms of supportive care. So how does myeloma bone disease? We'll address the first question of myeloma bone disease and how does it basically pan out. So there is a complex interplay between the malignant plasma cell and other marrow cells, and this results in the emergence of a microenvironment that is capable of enhancing both the tumor growth and bone destruction. And these can actually translate into situations such as a spinal cord compression, which could be due to a fracture of the vertebra or due to a presence of a soft tissue component, which may be causing pressure to the spinal cord. Hypercalcemia because of excessive bone destruction is a very, very common feature that we come across in myeloma, especially in late stage myeloma and patients presenting later with neurological symptoms, fatigue, constipation, etc. So pathological fracture because of weakening of the bone, especially on the weight-bearing joints, and intractable pain because of compression of the nerves induced by vertebral compressions and radicular pain, which is very common in myeloma and very distressing, and many a time feature with which the patient presents to the orthopedician or for that matter to the physician. There is also a rapid loss of bone mass in the form of osteoporosis that is quite rapid in myeloma, and of course the multiple osteolytic lesions that can cause pain when, especially those associated involving the ribs, for which the patient presents with excruciating pain while breathing. So this constitutes the entity of myeloma bone disease. And when we look at, this was a paper, even though a little bit older, when we look at why we need to address it on a war footing, is this particular retrospective study of 165 patients, which actually looked at the data, and it said that 20% presented with pathological fractures at the time of diagnosis. And the 1-year rate of pathological fractures went up to 40% even during the treatment of the patient. And even while having disease control, it was an ongoing process, and fracture rates continue to rise in myeloma patients. And 60% of the patients would sustain a pathological fracture during the course of the disease. And patients with a fracture have 20% increased risk of death by virtue of any skeletal-related event that happens. So it's a major problem, and the biology of the disease actually is basically an uncoupling of the osteoclastic and the osteoblastic activity, which we generally come across in terms of the osteoclastic activating factors such as the RANK ligand, the MIP-1 alpha, the interleukin-3, tumor necrosis factor alpha, which are all upregulated. And this results in a tumor-associated macrophage activation, which in itself increases the osteoclastic activity. And once there is an increased osteoclastic activity, the osteoclast itself produces interleukin-6 and XN2, osteopontin, BAF, and so many other factors, which again results in induction of the stromal cells to again, so it is sort of a vicious cycle, one begetting the other. And at the bottom line, what we see is the osteoclastic activity is profound, and the osteoblastic activity is suppressed. So thereby there's excessive bone destruction and resorption. And so we know that now understanding of the mechanism of this disease, we do understand that when we use agents such as bisphosphonates, they increase and improve the mineralization of the bones, and also has anti-osteoclastic activity, which results in improvement of the bone integrity. So there were two papers that I came across in the EHA, which were the e-posters relating to the biology of the disease, and which may in the future translate into being targets for improving bone health in these patients. So one of the first studies was entitled "The Complement C3A Activates Osteoclasts by Regulating the PI3 Kinase BDK1 SGK Pathways in Patients with Multiple Myeloma." So what the gist of the study was that there is an increased C3A C4 activity in myeloma, and which is significantly promoting formation and function of osteoclasts, while the complement C4A does not. And there is alteration in this ratio. So when the complement C3A promotes the formation and function of osteoclasts in the patients with newly diagnosed myeloma by regulating mainly the PI3 kinase, the PDK1 and the SGK3 pathway. And actually, SGK stands for stromal growth factor kinases. And when there were some inhibitors to the SGK inhibitor, which is known as an SGK inhibitor, the promotion effect, the promotional effect of C3A on osteoclasts was perturbed, and this could potentially be a target in the future. But these are laboratory data, and it remains to be seen. But certainly there was a significant reduction in osteoclastic activity, which is what we want in patients with myeloma. The second study was the use of the protein kinase CK1 alpha, which controls plasma cells and stromal cells, which in turn results in the RUNX2 expression, which potentially affects the multiple myeloma associated bone disease. So it has been identified that RUNX2 is sort of overexpressed, and that also increases the calcium deposits. So there may be a role in CK1 alpha silencing in bone marrow stromal cells, but it did not cause significant apoptosis by doing so, but it definitely induced osteoblastic transcriptional phenotype. So where here we are probably promoting the activity of the osteoblasts as against actually suppressing the osteoclasts over here. And therefore, there was a oncogenic role of CK1 alpha on plasma cells, which result in sustained RUNX2 expression in myeloma, therefore, decreasing the levels of RUNX2 in bone marrow stem cells, stromal compartment, would potentially improve the osteoblastic activity and thereby again bone health. But these are all preliminary studies, insights into the biology of the disease, and there may be a molecule that can actually perturb this pathway and thereby improve the osteoblastic activity. So how do we approach myeloma bone disease? And I'm sure Dr. Ajay has dealt with it, but I just thought it's important for us to just run through the imaging techniques. We do understand the age-old of skeletal survey, whole MRI, and in the last decade also the advent and increasing use of FDG PET in these patients. But whole brain MRI gives a better quantification of the disease, a better understanding of the bone marrow changes in this disease, and we do understand in the International Myeloma Working Group diagnostic criteria, all the three, CT scan, MRI, and the PET, have their independent roles as criteria for diagnosis, especially when they delineate foci in the bone. So, but having said that, there was one paper which looked at whole body low dose CT scans versus a low dose CT scan which is associated while doing a PET scan, and whether both of them were comparable. And this was a study which was dealt with in about a good set of patients. I cannot remember the number, but what they came about was that it is equivalent in terms of bringing out the extent of the bone disease in such patients. Therefore, suggesting that while we do know that a PET scan is really beneficial in identifying extranodal disease, a CT scan may have an edge in better delineating bone disease. So combining the two, which means using a whole body PET scan, low dose whole body PET scan, and a low dose CT scan, may perhaps give us better idea when we evaluate myeloma bone disease. So having said that, currently the recommendation for evaluating bone disease in myeloma is usually the whole body low dose CT scan, which is a novel standard procedure for diagnosis of lytic lesions in myeloma, and conventional radiography can also be used if whole body low dose CT scan is not available, but certainly the sensitivity and specificity of a whole body low dose is far ahead of a routine skeletal survey. In asymptomatic patient with no lytic lesions, whole body MRI has to be performed to identify any focal lesions when looking at a patient with for bone disease, and in especially marrow disease. And in presence of more than one focal lesion, the patients are characterized as having symptomatic disease, which we all know as per the International Myeloma Working Group diagnostic criteria. A PET scan may be useful for better definition of complete or stringent complete responses, and for evaluating progression of the disease. And we do understand also the utility of PET scan in the background of autologous transplant, wherein patients who have a negative PET scan post-autologous stem cell transplant tend to do better as against those who are positive. So, treating a myeloma bone disease, you do understand, besides the imaging and everything, there is a choice of bisphosphonates that we can use, the duration of the treatment. There is a consensus that at least 2 years has to be taken, but there is also data from the MRC group that extended use of bisphosphonates did reduce the skeletal related events in these patients. So there are newer agents. We do understand from 2018 when FDA approved the use of denosumab, which is a rank-Leiden antibody, which was found to be non-inferior in a non-inferiority study to zoledronic acid. But the advantage of using denosumab is always in a patient with renal failure, where we know that bisphosphonates is not useful, and we generally defer using bisphosphonates in these situations. But in those situations, denosumab may be used. What are the recommendations of bisphosphonates? All myeloma patients with adequate renal functions ought to receive a bisphosphonate, and symptomatic patients without bone disease assessed by conventional radiography. But it is not clear for patients without bone marrow involvement on MRI or PET scan whether it's useful. But having said that, if there is osteoporosis, etc., identified, it contributes to better outcome. And in cases of osteoporosis or vertebral fractures that are not due to myeloma, bisphosphonates should be given even in asymptomatic patients. It is currently unknown whether patients who receive very good partial response or better have benefits of further continuing bisphosphonates. And this is just a cartoon to demonstrate the importance of taking care of myeloma pain related to a vertebral compression fracture by using a balloon kyphoplasty, which is a useful technique. We use a balloon to inject a dye and increase the height of the vertebra, thereby releasing the pressure on the exiting nerves over there. But care should be taken for the integrity, especially if you're not doing a balloon kyphoplasty, you're just doing a plain vertebroplasty. An MRI is a must to see whether the integrity of the posterior elements are maintained, so that the cement that is injected does not leak into and cause, because it's a hyperthermic process, and a lot of heat is produced, and it can cause damage if it leaks beyond the confines of the vertebral body. So this is just a radiograph demonstrating on your left side the events and after post-vertebroplasty what happens to the patient. Next comes the problem of anemia in myeloma patients.
You have 2 more minutes.
Yes. Yeah. So in 70% of the myeloma patients, you do have due to bone marrow infiltration, suppression by cytokine milieu, and renal insufficiency, bleeding, infection, so on and so forth. So the recommendation is that erythropoietin may be initiated in patients with persistent symptomatic anemia. The standard dose is about 40,000 units per week. Hemoglobin level should not increase more than 12 grams per deciliter. Care should be taken. One should stop it, and should be stopped after 6 to 8 weeks if adequate hemoglobin response is not achieved. More important to understand that. And true or functional iron deficiency during treatment should always be evaluated for. The problem of renal failure, we do understand that it is mainly a tubular event due to inflammation and due to cast nephropathy. In the interest of time, I'll just rush through this. And we need to approach a renal compromise in 2 ways. Is there a role for conservative approach? The role for therapeutic plasma exchange in presence of high free late chains, which can be deposited in the kidney. We do understand now that there may be a role for high resolution plasma exchange. But having said that, there is no head-to-head. The head-to-head comparison did not reveal large benefit for a more expensive process. Yeah, so discerning use of anti-myeloma medication is also important. The problem of neuropathy, extremely difficult for the patient. Systemic medical management focusing on tricyclic antidepressants earlier on, serotonin, norepinephrine uptake inhibitors, and more recently the use of capsaicin, which is a local application, which is a transient receptor potential vanilloid, which is an 8% dermal patch, which when applied to areas with maximum, can induce significant benefits in terms of pain relief. So the problem of infection myeloma, recommended vaccination strategies, antimicrobial prophylaxis, there is emerging role for the use of levofloxacin in these patients. Thereby, studies have shown that it has decreased the infection rates in the myeloma patients. Selective use of immunoglobulins. Vaccination is an important strategy, especially against influenza virus is appropriate and is recommended. Vaccination against Streptococcus pneumoniae and Haemophilus influenzae is recommended, but efficacy is doubtful in these patients. Acyclovir prophylaxis we always use for against reactivation of herpes, especially for patients who are on bortezomib and on daratumumab. During lenalidomide and pomalidomide, antibiotic prophylaxis is recommended, especially as I alluded to, the use of levofloxacin, and prophylactic immunoglobulin replacement is not routinely recommended in such patients. So the issue of thromboembolism, the data is up there, but we routinely use aspirin, especially when we use IMiDs, more so when you use drugs such as thalidomide in our regimen. The role of pain management is something neglected. We need to identify what the root cause of the pain is and use generously opioids, and in those patients discerningly use a surgical intervention or vertebroplasty or radiation therapy, especially when a soft tissue component is involved. Complications, in conclusion, complication related to a disease in antimyeloma contributes significantly to mobility and mortality of a myeloma patient. Complications alter the performance status of patients to define a fit versus frail patient, and consequently there may be select and the dose of to reduce therapy, which may not be completely acceptable, but we may have to use it in situations for a frail patient. So appropriate management of these complications is crucial for both patients, especially in improving the quality of life. And with that, I will conclude, sir. Thank you.
Thank you so much, Hari. Would you like to take one or two questions?
Yes, yeah.
So Dr. Haritha wants to know, how long do you give bisphosphonate?
So the recommendation is at least for 2 years, a minimum of 2 years. But we do know that the MRC data, which demonstrated that extending the use of bisphosphonates might again continues to reduce the skeletal related events, and that was a large study which conducted. So at least for two years for sure, and you may want to extend the duration of the frequency of the bisphosphonates maybe to once in 3 months or so, beyond 2 years.
Thanks. Dr. Abdullah wants to know that if you have used it for 2 years and then when patient relapses, can you use it again?
So we must understand that zoledronic acid is just is one of the, not a very potent anti-myeloma, but it contributes to that. It may not have so much of a benefit in relapsed in a relapse setting beyond after they have completed 2 years. But having said that, many of us still continue to use it. There's no real data to say anything about it.
Thanks. Dr. Adel wants to know, can you use osteogenically differentiated stem cells to treat the bone repair?
Well, that's a bouncer for which I have no answer actually.
Okay. Dr. Abdullah wants to know, do the osteolytic lesions revert back to normal?
No, they don't revert to normal, but you can see a lot of sclerosis that develops and healing process that develops, but radiologically they may still persist, what we call as burnt out myeloma.
Is Dr. Sharad around? Sharad,
yes, sir. Yes.
Here's a question for you. What is the survival data after CAR T therapy?
Yeah, so that is just evolving. Like I put up the data, I think most of the curves didn't go beyond the 1 to 2 year. The longest was about 18 to 24 months data, which is there. So it's a recent therapy. So clearly there is more and more fine tuning. And if you looked at the Cartitude study that gave such wonderful results, but we need longer follow up. So every meeting we are going to get more and more follow up data. But clearly there is already some relapse being documented. So time will tell. But I think we have about 2-year data as of now.
Thank you. Any one of you can take up a question. Roshni wants to know. Patient is on DARA, requires blood transfusion, cross-match problem. In India, how do you sort it out? Should you keep the blood cross-match before using DARA?
So when you talk about using this, it's a common problem and something that the blood bank has to be aware of. There are eluting agents because the RBC gets coated and sometimes it may be difficult to cross match. So the answer is not to keep blood because I did have this discussion with my blood bank also when on some patients. We can't indefinitely keep a blood for cross matching, so it may be during the initial phase of treatment, but ideally the blood bank has to know and they have to go ahead with the cross match, and even if there are minor cross match problems, if there is largely a compatibility, they generally don't. But ideally, you have to use the eluting agents to do a proper cross match.
Thanks, Hari. Dr. Haritha wants to know what is the best way to do MRD assessment. To cut the story short, you can do flow on the bone marrow. If you know the initial changes in the plasma cell, you can use the sequencing, that is molecular methods, and you can do PET scan. I think we have taken up almost all the questions now. Yeah, that's the end of it. So I kept a little bit of speech, but I don't think I have time. I'll rather have Alkem give the speech.